website, you got Robert, me, is Dr. Laura online?
She's here.
Is I here? Oh, you're here. There you are. Sorry, never mind. I'm looking around. All right, so we have 3, and then on the pet side, Andrea, Greg's online, right? And Kimberly. So we have 2 of you. Anybody here from Andrea? Is she okay? Yeah. Okay, so we're okay though. So we have enough to do any action or roles. Now that it's 2025, I get to officially wear glasses. Okay, so we have the March SEOW minutes in the packet. First up from the March 4th meeting. Any questions or comments from Workgroup members? If not, I'll take a motion to accept as presented.
Make a motion to accept as presented.
The second.
This is Kimberly. I'll second that.
So motion from Robert, second from Kimberly to accept the meeting synopsis. All in favor, say aye.
Aye.
Okay. Anybody against? No. Okay. We have an interesting second presentation, which is going to be lengthy. So we're going to get a short one out of the way, which is the medical quality performance metrics. And that is going to come from, well, I gotta catch up. Who's doing
I think I'm doing that, Bill.
You're doing
Thanks.
it. Okay,
Yep.
crank it up. Right.
So the first attachment, or I guess it's the second attachment after the meeting synopsis in your packet, is a brief slide deck where we're going to review just some information on OAB and PEP clinical quality measure performance guarantee. If you'll recall, back at the January meeting, the work group received presentations from the carriers that went through their results for measurement year 2023 on these clinical quality performance measures. All carriers met targets sufficient to meet the guarantee and retain all fees at risk. A little bit of background as a refresher in terms of how the guarantee works. Each of the medical plans have a set of 18 HEDIS measures under a performance guarantee in their contracts. The carriers must meet established performance targets under this guarantee, and if they don't, they're required to return 5% of the health plan's administrative fees to OAB and PEP. And as noted for the most recent calendar year for 2023 data, all carriers met the targets necessary to retain the full amount of fees at risk. On the next slide, you'll see it lists the 18 current measures that are included in the health plan contracts at risk. On the subsequent slide, it shares a little bit of information about targets and scoring. And there we go. I know sometimes it's a little bit of a lag on the Teams meeting in terms of the slides advancing. But note the targets for each measure are set at national percentile levels. So all health plans nationally report HEDIS measures. NCQA is the steward for those measures. They identify the national percentile rankings in terms of how the distribution of scores fall. We use those national percentile levels to set targets for each of our, for the measures for each carrier. And in terms of scoring on those targets, that's listed, noted on the slide in the bullet points. Carriers receive 1 point for the measure for reaching the 66.67th percentile, 2 points for reaching the 75th percentile, and 3 points for reaching the 90th national percentile. And then carriers must achieve a minimum total score to retain the fees at risk. Next slide. Additionally, and this is with regard to some additional reporting that we capture that is not at risk, not currently under a performance guarantee, but there are certain additional measures that carriers report for various racial and ethnic subgroups. Our contracts include reporting on these subpopulations for these measures. And we do not yet have targets or fees at risk in contract, but I think it is safe to say we are going to be looking at how performance on these measures appears once it's reported. This racial and ethnicity breakdown is a little bit newer for NCQA reporting for HEDIS, so we're capturing the data And I think it's, certainly feasible to say that we may look at setting targets in the future on these. For now, they're report only.
Quick question on that one. Dr. Whoever, glycemic status, what is status of glycemic status as opposed to the value? Like that they check, that they just got checked?
No, it's for the diabetes care measure. It's that I guess it's really that their glycemic level, it measures pore control, that measure. So if they're above 9%, they're considered in pore control. And it's NCQA terminology. They used to call it HbA1c pore control.
Okay.
And so you want to have as low of a score as possible on that. You want more of your measures in good control. Periodically, like NCQA will tweak the terminology or the nomenclature on the measures, but it's still measuring poor glycemic, like the percentage of your population that has poor glycemic control.
And that one's a weird one because it's reporting the less ideal state, whereas everything else is going.
Yeah, okay, I got it flipped. I just didn't know how they were saying status. What does status mean? Right.
Yeah.
Okay, thanks.
Yeah, absolutely. Next slide. And so on the next slide, we have our recommendations for renewal contracts. Staff and Mercer are recommending that all 18 of the current measures be retained for next contract year. We're recommending that we retain the current point thresholds necessary for carriers to retain fees at risk. So basically leave current contract parameters unchanged in that regard. And we're also recommending that we retain the targets at the 66.67, 75th, and 90th national percentile unchanged. There is a note there that I think we do want to continue to monitor immunization rate measures against targets. There are some observed differences between OEB and PEB. On adolescent immunization rates, all of our plans for both OEB and PEB are meeting the national 75th percentile. On the childhood immunization rates, which looks at a younger child population, the rates for OEB are notably higher. And for PEB, in all instances, they're not meeting the HEDIS 75th, so they're lower than that. And so I think there is definitely a note sort of that we should continue to monitor that and watch how those rates trend. I think we, as a group, have kind of speculated about why OEB rates might be so higher on childhood immunizations. I think there's potentially some influence perhaps that the OEB population is skewed toward educators who spend a lot of time with kiddos in schools and in classrooms and perhaps are more in tune with the benefits of timely immunization. So that said, I think we flag that as something we want to continue to watch, but we're not recommending any changes to targets or scoring at this time. So today, I think we're looking for SEOW consensus with the recommendations so that we can move forward with following these steps in our contracts for next plan year.
Question. Who gathers and reports the national percentiles?
So the national percentiles are reported health plans that participate in HEDIS and track the measures, report those. It's the National Commission for Quality Assurance, so it's NCQA.
Who are they under?
They are a quasi-governmental
NCQA. And
They're funded by
well,
federal agency?
well, I can't speak to whether some of their funding might be provided by federal sources, but they do also health plans that participant, I believe, pay fees, membership fees. I think they have
Okay, so it's not a coin toss whether they're going to be there next year or not, right? It's not better than that.
My understanding is that it is not, in that they have durability. That I have not heard anything that indicates they wouldn't be around. Fair question.
We'd ask that now. Right?
Yeah,
So,
fair question. Yeah.
questions from the board? Any comments about the measurements we're taking? Right, I think they're all pretty good for, especially on our preventative and our shift left stuff. Those are kind of the metrics we need to see. Right. So I'll take a motion to accept the current HEDIS measurements and the ones we measure against and the ones we track as presented.
And this would be for PEB and OEB.
Oh, sorry, good point, right? All right, so let's start with OEB because that's me, right? So for the 3 OEB members here, are we good with that? We'll just vote yes, then yes, yes, yes. Okay, so that's a go for OEB. And then on PEB, Greg, you're online. I don't know if Andrea joined yet or not.
Oh, yeah, nope, I've been here.
Okay, good. So on the PEB side, Kimberly, Andrew, Greg, are you all yeses? Can I hear 3 yeses on
Yes,
accepting that?
I'm good with
I'm good.
as presented.
Okay, I hear 3 yeses on the PEB side. So I think that's a go then for continuing as we have it. Okay.
Yeah, thank you so much.
So now we're going to get into our primary topic of the day, which is how we're going to better our efficiencies from an evidence point of view. We'll talk about financials in your individual board meetings, but we're going to learn a bit about the proposal that is on the table of engaging an outside firm for improving our efficiencies and our medical expenses. And who's leading off?
I'll kick it off, but the thing is I'll be handing it over to Andrew because we have one other quick thing that we have to address before Garner today,
Okay.
which is a VH360 for MODA.
Oh.
And so we'll do that, and then here's an overview in terms of what we're going to hit when we get to Garner. So we're going to give you a bit of an overview of what it's about. Then we'll talk about the top provider selection, member access, health equity, and then the member experience implementation options, and then a summary of key finding and a Mercer recommendation at the end. So that kind of gives you a preview for what's coming. But before we do that, though, I want to turn it over to Andrew to address the VH360 and this is just a PEP perspective.
It is. Thanks, John. Yeah, this is a PEP only item, and so this is a program that's already in place on the OEB MODA plans, but not on the PEP side. And so this is a follow-up from the behavioral health point solution evaluation that we've been doing in this group over the last 2 months. And so I'll just sort of summarize the program a little bit and talk about some of the history as it relates to PEP in this program and prior discussions. So the intent of Behavioral Health 360 is really to provide additional behavioral health resources for members. And so there are different components of the program that are sort of integrated together to accomplish that. So a big part of the program is navigation. And so that comes in the form of behavioral health champions. So these are folks that, as a member, you can call and speak with one. They can help you sort of determine what's the right resource for you based on your need. They can help you with provider availability and scheduling. They also follow up with members after they've done their initial visit with the behavioral health provider, just to make sure that their needs are being met with that provider. Another component of the program is around decision support, which comes in the form of a member questionnaire. And so a member goes through a questionnaire based on how they're answering those questions. Similarly, they'll be navigated to the appropriate resource. And then the third component is around some network expansions related to these specific subcontracted vendors, including Gemini, some expanded services with Hazelden Betty Ford, which is a substance use provider, and Spring Health. So Spring Health actually is included in the PEP program today. Spring Health is a navigation platform. It's also a behavioral health network expansion. It's a bunch of additional providers that are being made available to members. And so that's sort of the program in a nutshell. When we've talked about this program over the last 1 and 2 renewal cycles, some of the sticking points from PEP board member perspectives were really around the fact that there was an additional administrative fee for this program. And so the sense from the board was that these services should really be baked into the sort of core functionality around MODA 360. So they're sort of general navigation services. And so this cycle, MODA has proposed to offer this program with no administrative fee. They've also made some enhancements around incorporating social determinants of health into that member questionnaire. And so as a member, when you go through it, the tool will attempt to identify if there are social determinants. And if so, it will make referrals to that member for community-based organizations. And so this is something that we think makes sense for PEP to consider for 1/1/26 for this upcoming renewal. But I will pause there and see if, I'll just open it up for general comments from board members from either board. This is in place with OEB, so to the extent there are comments around how that's going, we'd welcome those as well.
Let's go to PEB members. Go ahead, Camille.
Do we know how much OEB members are using this, like utilization? I don't know.
We know, yeah, that's a great question. We do. So we have that slide in the appendix. The behavioral health champion utilization is generally on the low side, but the sort of self-serve member questionnaire is much more highly utilized. And there's been some really good initial results with that enhancement around social determinants of health. And so that's driving a lot of the engagement in the program. While the utilization is low for the champions, for those who are using it, it is still sort of a value add. I mean, it's helping navigate those folks to the appropriate resource based on their need. But that component has been a little bit on the low side.
Thank you.
Greg and Andrea, you have a quick question before I chime in?
No, I just want to say it's nice to see this. We did have quite a discussion on this last year. Thank you.
Yeah, I want to ditto what Greg said, that I'm glad that this has come out to this, because I think it's a lot of what we discussed.
So I'll chime in on, we acknowledge on the OEB side that it was costly and low utilized at the beginning, but it is ramping. Mental health is difficult, to wrap around, but when a person is in, I'll just use the word crisis, right? We need to give them multiple avenues, to access healthcare, the one that best gets them into the system. And even though it's a little bit on the costly side, it is ramping and getting better, but it is something we need to just have that there, because the price of them not getting in is tremendous, and not just on the system, but also on the individual. So that's my opinion. That's just stating that. So I'd like to keep that. And I know, we in OEB are trying to get into our member database even harder, especially on management side, to get mental health and behavioral health utilization higher. And we're choosing to fight that, to get our members to be more engaged in these systems, rather than try to cost control it. You can tell me if I'm stating out of the box, but that's how I feel. We need to get our members more educated on getting the help than we worry about the cost of it, because it's really a crisis. So Mike, that's my thinking. Robbie, you can chime in, or Andrea, this is your field too. So
well, this is great. I'm kind of surprised that we're gonna little late on the game adding the social determinant of health. I would like to know why now and not we kind of heard before that we wait so long, because it's crucial for any patients to have that, and especially that we know the mental health after the pandemic and during the pandemic, how much stigma we have with these conditions. So I think the education is key, and then also all the tools that we can support some members, that would be great.
Dr. Laura, I think it's not so much that MODA's only now adding aspects of social determinants and health services to membership. I know Erica's here also. MODA's been working to offer support services for a long time. It's just connecting that to BH360 as a new method of connecting members on top of existing methods. That's the development with BH360.
So in the beginning, it was difficult to kind of plan for the entire plan, and you were doing like in phases, or how that worked?
Yeah, I think MODA initially, Erica, if I'm remembering the history on this, it was when members were calling in to MODA's overall navigation and advocacy service, that then the support specialist there would connect members with social determinants of health services through that customer service entry point. Is that right, Erica?
Yeah, you want me to speak on the evolution just a little bit quickly? So Kirsten's right. We have been working on connecting members with resources for SEOW for a while, but it's something that we continue to evolve just over time and will continue to evolve. So originally, we did start, the way that we were connecting members to resources was through our navigators. So that's when members come in, like calling customer service. We've expanded that. So almost a year ago, we built an actual SEOH team. So that's a team of advocates that are dedicated just to helping members find resources for SEOH needs. So we have that, but as you can hear, and I think everybody knows, one of the most difficult things is actually getting members referred into programs and getting the awareness out. And so we've continued to try and expand on, okay, how can we better get the right members to the right resources? And so one of the ways we've evolved that is through BH360. So now, and the way we like to think of it is there's a single front door, but there's no long door either. And so we are able to refer members from the champions. If they're working with a champion, they go through that assessment and it'll refer them over to the SDOH team. And then inside the member dashboard, as part of BH360, we have this assessment. The assessment's goal is really to help identify what the next best step is for that member. And so members go through that assessment. The first questions that are asked are a series of SDOH questions. And so members will go through there and they'll click them. So if they click certain questions on there that indicate an SDOH need, different things will happen. One thing that'll happen is it could generate a referral to the SDOH team. The SDOH team will get that, reach out to the member, and then they use a platform called Unite Us to help connect members to resources in the community that can help them. If they can't find resources through Unite Us, they will do all sorts of means to find resources, including Googling, which is something they absolutely do. And then they put them on a plan and they'll follow that member through the plan until they kind of close that member out and are able to connect members to the resources. The other thing we do with those SDOH questions is we are just now starting to incorporate the EAP into that. And so when they answer the questions, it'll trigger different ancillary resources from the EAP, and then it'll generate a referral over to that specific ancillary service instead of just referring overall to the big EAP. So yes, we continue to evolve, but I think the hard nut to crack, and that's something John would say, I'm just pulling from him, is how do we get members to the right resources? And so that's what we're really trying to do with BH360.
Thank you.
Did that help?
Yeah.
Okay, good.
Oh, this is Andrea. Can I make a comment real quick?
Jump on in.
So I think that the question that was asked on like why it's taking so long, I think for PEB is because we had a discussion that because the mental health is so important, it has been, it should have been, as far as the cost, included with what we were already paying. So our concern was that we were adding something on that we were going to have to pay for that should have been covered by the plan already. So that's why there's been a delay.
On the PEP side.
On the PEB side.
Yeah, we've had this in OF since the idea was created. We jumped on it in OF just because we needed that extra avenue. We were trying every possible thing we could try to get members to engage in the behavioral health programs that we had, but we had so many that it became complicated, right? So we needed that coach. We actually couched it that way, right? We said we need a coach to help you get through the system to get you to where you need to be faster. That's why we pulled it in. Robert, anything?
No, also.
Is this an action? So this is on PEP. So on the PEP board, on the PEP CL side, the question is, do you have a recommendation from Mercer to add this as the financial change with the exception, with the administration fee now being waived for you guys? Is that something you want to recommend to your board?
This is Kimberly. I think that we should recommend it. Speaking from Department of Corrections point of view, any and all mental health additional care that we can give our staff, the better. We know we need it.
Yep. Andrea and Greg?
This is Andrea. I approve.
I agree.
Okay, I got 3 positives. So SEOW will recommend to the PEP board that you add this as part of your upcoming renewal. Okay, so from staff, you got, that's good? Yeah. Okay, got it. All right, so second item on your agenda is Garner. I think we gave a little bit of an intro to this at the last month's meeting, but let's get into the details.
Next slide. Next Next slide. Okay, so thank you for joining today's conversation on Garner. Our purpose today is to provide the members of SEOW with the information they need to come up with recommendations to the boards. And we want to acknowledge at the get-go here, we'll be providing a lot of information in a fairly short time. So just want to acknowledge that and also encourage anybody to ask questions as we go along, and there really are no bad questions. And you might wonder how this came up, Garner. So as part of the role of Mercer and the carriers is to bring innovative solutions to SEOW and the boards to help the boards achieve their goals. And this is the context that Garner was surfaced. Garner was founded in 2018, has over 400 clients, including some of the large Fortune 500 companies, and also some large public sector organizations as well. Mercer has several clients that have Garner, including some of our key clients, and they have generally found Garner to be valuable because they've retained it, even though for some of them they're not using Garner in exactly the same way we're talking about it today, because they're, Garner is a platform that can be used in different ways. So just to be clear on that. We have two representatives from Garner today. So we have sitting over at the table next to Robert, and so we have Kurt Sonska and Nick Momolo, and so they're here, and we'll be doing a demo of the app a little later, and then also to answer any questions, because again, we've taken a deep dive over the last month into Garner, but there's still things that we're learning as well. So also in this, we want to acknowledge the efforts of Moda and Providence and Garner to get us to the point where we are today. And if there's a decision to move forward with Garner, we also just want to be clear that those contracts with Garner will be held by Moda and with Providence. So since our last meeting, we've taken that deep dive that I was talking about to better understand Garner, and what you'll see today is kind of a distillation of all that information. And then just to be clear, so if implemented, Garner would be it would be on Moda, so it would impact Moda, both OEB and PEB members on Moda, and then also PEB members on Providence as well would be impacted. And as noted earlier, we'll also be focusing on, how do this top provider selection, because that's really a kind of a key component of what they do. Member access, obviously, just want to make sure that members have access to the top providers. We're also looking things through a health equity lens, and then also talking about the member experience in some depth. One of the things that we won't be covering, and Bill alluded to this a little earlier, is we're not going to be covering some of the financial aspects of it, particularly around the incentive level. So the incentive level is something that's probably best discussed in each of the amongst each of the boards, and then we'll get into what that incentive level is in a few minutes here. So that's kind of some table setting. So let's move on to the next slide and figure out what is Garner. So next slide. At its essence, Garner provides an incentive for members to use high-quality, cost-effective providers that Garner calls top providers. Garner's algorithm to identify top providers, and it identifies top providers in the Moda and the Providence networks. So top providers are inherently, a subset of those networks for both Moda and Providence. And then the incentive, so what they're doing is they're incentivizing members to use them, and the incentive is by way of a reimbursement of out-of-pocket expenses, so deductibles, co-pays, co-insurances. So for members who use top providers, they'll have some portion, if not all, of their out-of-pocket costs reimbursed. And there's an annual limit, to that incentive, and that annual limit is something that the boards would establish. And essentially, how the Garner model works is the higher the amount of the incentive, the greater percentage of members who are expected to use top providers, and the more use of top providers, the more savings. So that just kind of getting to the point, that's kind of how it works. So there's an incentive to increase use of top providers, and use of top providers should bring savings over time. So in addition to the incentive, Garner provides transparency for members to find high-quality providers. And high-quality providers are expected to yield better outcomes for members. I think the other thing to do is to think about too is really Garner as a multi-year solution. That, even though we're very focused on Garner for this renewal cycle, to the extent that members increasingly use the top providers, there's a real opportunity to bend trend over time, and reduce the need for plan changes and subsidization, which will be a lot of the board discussion for both boards this year. Let me just pause there before going any further.
John?
Yeah.
Yeah. Is, just so I understand, is the decrease in copays and cost sharing at the point of service, or does that go into a fund?
Yeah, no, that's a good question. And we'll take a deep dive, and Andrew will also be walking through this as well. So good question. So the thing is, you're still going to have to put the money out, and then you get reimbursed for that money later. But the thing is, what you'll see is it's a fairly seamless process, because the whole process is triggered by you looking for your provider. Once your provider is tagged in the system or pinned, if you prefer, then as you have what happens is, your claim gets processed regularly, through Moda, through Providence, right? And then there's a claims feed that goes to Garner, and then that's automatically reimbursed, and you can decide whether you want it as a check or if you want it direct deposit. Does that help you? So essentially,
Yeah, that's what I thought. I just wanted to clarify.
yeah. So it's not at the point of service; it's reimbursed on the back end. Okay. Next slide. So I think that, the key thing is that how this benefits both there are not a lot of win-wins in healthcare if you've been doing this for a while. And, this is a bit of a win-win in both terms. It helps both members and the plans. So for members, the use of top providers means improved outcomes in terms of, less unnecessary care and, fewer complications. And if we're talking about really large procedures, it's improved mortality as well. And then the other thing too for members is it's not only improved outcomes, it's also lower costs. So the thing is, to the extent that you're using the top providers, a portion of your out-of-pocket costs will be reimbursed for members. And then again, these are deductibles, copays, and co-insurances. And as we talked about, to the extent that Garner yields savings as a result of people using these top providers, there's an advantage in terms of premium contributions going forward. And then from the board's perspective, there's also gains from Garner in terms of it assists the board goals of providing members with high quality, cost-effective care while concurrently reducing out-of-pocket costs. So if Garner generates the projected savings, I think the other thing too is that there's less of a need to make plan design changes and subsidize the plans going forward. That's the goal here, both in this renewal and then going forward. If there are no questions, we'll move on to the next slide about the value of transparency. So if you think about incentives, incentives can be carrots and sticks, and really Garner is really a carrot. Because the thing is, if you choose not to use Garner, you still have the same level of benefits. You just don't get reimbursed for your out-of-pocket costs. So essentially, you're no worse off for not using it. But if you do decide to use Garner, you get that incentive. And again, the boards would decide, what was the annual amount of that incentive. The other thing too that we want to point out is that the incentives are compatible with all the plans. So I think that there was some question in the last meeting about how this would work with high deductible health plans and HSAs. They are compatible with those, but you have to kind of make sure that you're following, you're compliant with the IRS rules. So members can only receive, members who are on a HSA or an HDHP plan can only receive reimbursement for their out-of-pocket costs once the IRS minimum deductibles are met. So that minimum deductible for this year for an individual is $1,650. So once that $1,650 is met, then Garner can reimburse the out-of-pocket costs of members. And again, this just impacts some of the MOTA plans, the MOTA HSA plans, and those are the only ones. So hopefully that kind of is a little ground setting in terms of a brief overview of Garner, and then we'll kind of take a deeper dive into these 4 different areas. Any questions? Yeah.
John, you said it's up to the maximum of the HSA guidelines, so that's $1,650. So that's regardless of what the actual plan design deductible is. Correct.
So the thing is, essentially, think of it this way. So say that you have an HSA plan that has $2,000 deductible. So the member is going to have to pay $1,650, but they can use the Garner reimbursement for the difference between the $1,650 and the $2,000. Yeah, so I appreciate that question. That's a really good question, Georgianne, because it helps illustrate the point. Yeah. Okay, we'll dive into the next section. Next slide, please.
Okay, so this section I'll kick off, and we're going to dig deeper into sort of how Garner approached towards provider designations through a performance score to designate the top performers. Really when addressing costs, once you move beyond the plan structure and fee, the next level or layer of cost, where I would like to position as value, really comes down to looking for the intersect of quality and the variability in cost within any plan design, plan network of providers. So what Garner has done is try to analyze that intersect and provide the capability of what I would say is the promotion and enabling of health service literacy, right? So plan structure and fee, very concrete. But underneath that, it is about members and our associates' choices in terms of who they select, how they approach decisions with healthcare services and utilization. So we need to think about this, to John's point, is sort of it's a strategy. Of course, the cost is one key outcome of it, but I view it as the beginning of helping our members move from a passive to an active health consumer mindset, right? So instead of assuming that this is there, it is creating visibility, transparency for things that should matter. It's all about members' choice. You can still use Google, and you only get this level of intel. This is that next layer, and at the end of it is equipping each of our members in those choices and decisions with the financial benefit both to them as well as the plan. So in that context, what Garner has done is sort of approached it by looking at a lot of data and really tried to isolate and identify those providers in that upper left quadrant there, where it is, to the extent that we can see it visually and quantify through data, the intersect of measurable quality, and I'll go into sort of what falls into that set of measures relative to cost. And it's not about the lowest cost. So you're not seeing the cost is shifted right to that a small sliver. It is to the capability of the data saying, hey, in that quadrant, there's a good enough balance and trade-off. In the absence of any more, in the absence of not asking, those are the providers to consider, and it's still a member's choice. So some of the patterns that they've looked at are sort of how orders are made for imaging and lab, where we know there's variability in cost in terms of what is being ordered, but also where the patient's being sent. The use of generic and brand medications from a prescription and pharmacy perspective, surgical versus non-surgical intervention. In medicine, we believe, unfortunately, that more is better, but that's not the case, right? So more is not always the better treatment or solution. Surgery is not always the best thing relative to conservative or non-surgical treatment. But then how would the average consumer know that? So those are the things that will be looked at. Next slide. So in defining the top providers, what Gartner has done is basically mine a lot of data. So they have access to, and you guys can correct me if I'm wrong, my understanding is about 75% of the available data that's out there around healthcare claims utilization across geography, plan types, all that. Because at the end of it, as a physician myself, speaking for myself, we practice a certain pattern. So if you can uncover that, you know my biases and tendencies towards certain care. Now that could be translated into the profiling of quality and cost. And that's what they've kind of done, and then present that in terms of a performance score. They've localized it, so another unusual characteristic of healthcare is regional, right? So practice norms here may be completely different than the Southeast. So we have to optimize for what is available within your geography, and they'll do that. So even though they're looking at the national data and all available data at the macro level, at the end of it, they're giving the recommendations and the relative ranking specific to Oregon in our context. They're covering the top providers that are relevant. So there's like 89 specialties that they're sort of looking at and doing these relative performance comparisons. So what we'll do next is kind of dive into the quality aspect and the cost. Next slide. So when it comes to the quality, there's sort of looking at three key categories. So in aggregate, there's about 530 metrics currently. This will be evolving over time. There's sort of be things that we start to learn and understand more, that they're going to, you know, the beauty of big data is you're never big enough, right? So my assumption is they're going to keep working on that. A good majority of their metrics are what they call protocol metrics. So these protocol metrics are basically things that should or shouldn't be done typically. It's independent of severity of illnesses, right? So these are things like HEDIS. That's just a subset. There are many other ones based on guidelines and other sources, and they're tracking those and quantifying that at the provider level. The other two categories do require some sophisticated analysis because it is correlated to the severity or the acuity of the condition, right? So sicker individuals with certain conditions may require high utilization. So they're going to account for that. And there's like going to be sort of the utilization intensity. So broadly speaking, if your condition is more severe, it can be expected that you're using more services. But what is that right level of services? So that gets factored in. And the other one is going to be outcomes. Again, if your condition is more severe, achieving a favorable outcome is technically harder. So how do you factor that in? So they're accounting for that statistically. And in that aggregate, you're getting the performance score for that physician relative to that specialty. Let me pause there on quality. Questions about that? Oh.
This is Andy. I have a question. When they look at the different standards, or they're looking at the doing the conservative treatments, do they take into account patients, the amount of time that they have to spend either doing physical therapy versus surgery, like, you know, what that impact is on their life type of stuff?
You know, like the Gartner folks answer, I don't believe so, because those are protocol based, right? So they're just utilization, presence, absence.
That's correct, yes. So we would look at all the protocols on whether or not minimally invasive techniques are recommended for that particular intervention before jumping to surgery. However, we're not considering, you know, the individual and the length of time that, say, physical therapy would need to occur before that surgery.
So Dr. Chuang went into a lot of detail, and I think there's going to be some more here around just like how deep we get into sort of the subset of quality metrics and the subset of cost metrics. We really kind of use two baseline metrics as we evaluate quality. For quality and cost. For quality specifically, we actually use a metric, and it helps us really compare relativity from one physician to another around clinical appropriateness, around overall outcomes, et cetera, which is healthy days lost. So it's this concept of healthy days lost. And then the concept that we use around cost is truly just the per member per month impact on trend on the medical and pharmacy program. So We do weigh the quality and the cost generally pretty equally. So to your question, Andrea, when we think about the impact of physical therapy versus surgery, we are looking at quote unquote healthy days lost for physical therapy versus surgery. So whereas somebody might be out of their work environment for an hour or two a day, once a week for physical therapy, we're comparing that to the healthy days lost from going to do a spinal fusion surgery or a full knee replacement, when really physical therapy was a more optimal pathway of care for that particular patient's presenting condition. So
Right.
To answer your question, we are looking at healthy days lost as well.
Perfect. That's exactly what I wanted to hear, is just so I can explain to my constituents these things. Thank you.
Sure. Good question.
I'll ask the question. So being in the large data model business, so eventually a large data model will pump out something ridiculous. And so what is your quality checking and how often is it reviewed for just that things are behaving correctly in your mathematical models that are being used? What is that quality control checking process in Gartner?
Mm-hmm. Yeah, so we are a data and technology organization at our core. That is the majority of our employee base is focused on that data, on the research. And so we have our clinical advisory team that is scouring latest medical literature, looking at journals to include latest medical research and evidence-based protocols into our methodology. So that's updated on a weekly, at the most monthly basis. So our entire quality metrics are evaluated on a monthly basis.
But in terms of ongoing QA, QC, that's happening on an ongoing basis. So yes, we're uploading additional clinical literature guidelines on a weekly basis. We're typically uploading claim data on a monthly basis from the various different data sources that we're collecting that from right now. And there's constant QA, QC that's happening from a data engineering perspective and from a clinical oversight perspective too.
And then
I know they mentioned it to me, but I'll just comment and correct me if I'm wrong. You guys are not doing this currently. You're adjusting for some of the confounders that may be some of these factors. Going forward, you're going to start to look for unintentional biases and correlations with potentially race, ethnicity. Just, for whatever reason, tend not to recommend a certain treatment for certain subsets that is measurable. And so you guys can look at that.
That's correct. Yes. So we'll risk adjust currently for looking at the metrics and how they relate to specific populations and specific interventions. And a big part of that in improving is that those social determinants of health as well.
And then my next question is, without getting into details, just the process for a customer, which in our case would be Moda and Providence, with some oversight from us, but Moda and Providence would be your customers here, that they come back and like say, love you guys, you're doing great, but here's a situation that didn't make sense, right? What is the process for the feedback to say, hey, maybe you should look at this and see that this, we love you, but this didn't make sense?
Yeah, ongoing conversations. So we're going to spend most of our time today talking about our solution that is ultimately an employee benefit offering, but we also do work and partner with some different health systems and provider groups across the country, and that type of bi-directional feedback on, hey, we think this metric's not tracking appropriately, et cetera. Those are conversations that our team is constantly having, whether it's with a health plan partner or with a physician group partner that we have as a customer or a health system, et cetera. So always open to having those conversations and making sure that things are being right-sized appropriately too.
That comment, the biggest part of the sell here is that you're not just picking the lowest cost provider,
Right.
because that's what members will immediately gravitate to, right? So we have to make sure that the communication standards are saying, no, there's a lot of data coming in here, and that, this is not just picking today's lowest cost provider for getting you something.
Overall
right?
cost of care.
That's what people will jump to. So we need to explain it well. So that's why I'm asking companies.
Okay, Rose, next slide, please. Okay, so the quality is one metric category. The other one is around cost. And kind of like the quality, there's multiple dimensions that contribute to the cost of care assessment. The ones that we typically expect that are sources of variability in cost that are no other reason than just the way it was negotiated. Site of care, hospital versus ambulatory care settings is the most obvious ones. There's a cost associated where you have those procedures. Pharmacy utilization, and then also the type of surgery. The most obvious one, commonly known to most people, is just the choices that physicians make between doing a minimally invasive versus just doing a big cut and doing the surgery that way. Both, there's a cost implication for the procedure itself, but obviously from the recovery and other factors that are important as well. So all that kind of gets considered. Medical utilization. This is where we're looking at sort of avoidable high cost of limited value or being too aggressive in going to those more aggressive treatment options. The most common one that we reference is, for example, low back pain that leads to a spinal fusion. I think spinal fusion medically should be the choice of last resort, given the how invasive it is and the outcomes that are very all over the map. So looking at that is how the cost factors come into play. The necessity of certain procedures before going to surgery. Some things are best practices because they prevent downstream risk. Other things we've always done it that way. It's just habit. Now, how do we kind of pull that out of the system through transparency and choice? And the last one is the cost of service. Before the EMR, we used to joke and say this was the most expensive. I'm holding a pen for those on the screen. This is the most expensive medical instrument because everything starts, all cost utilization starts with what I ordered, right? So we know there's a pattern to that. I'm biased towards a certain treatment protocol pathway. So understanding that is sort of the last element that contributes to cost that Gartner looks at, which is the pattern within the physician and how they approach the care of certain conditions. Let me pause there. Questions around the costs and the Gartner's approach?
I have a question, but I have a worry. So what I see as a non-medical professional, but observing this industry in detail, is a lot of the, especially the variation in hospital costing and high-end service costing is distributed costing. This is my MBA guy talking here. And that's not very good. It's what we use in the military, it's what we use where we just distribute cost randomly. And this is going to drive more towards activity-based costing because we're going to look at the actual value between two services that might be equal, but they do two different costing models and pick it on that. So it's going to change as this becomes more prevalent in our national healthcare system. It's going to change the way people have to do costing, right, and billing, because you're going to have to get more detail, so like in your activity-based costing, right? And so that's what concerns me. It shifts the equilibrium in how the hospital costs are done. Why one hospital is half the price of another hospital. It's just the way they cost control. So that's going to really change the way we handle the model of costing, my opinion.
And the site of care is one big dimension of this. And historically, that's the only thing that we've been able to easily identify as high cost. This gets into before you even get to a surgical or an inpatient stay, there's a lot of cost variability, again, driven by the ordering pen. So how do we start to address that? Where it is tends to be activity-based cost and less cost shifting and other things that happen.
From your chair.
Yes.
But not how hospitals bill.
Correct.
Right. That may be a good thing. Maybe.
And about hospital care, I mean, we have a Senate bill that kind of helps with that a bit. And again, there's a lot of cost before that element of site of care becomes the major cost differentiating factor. So, yeah, like I said, this is an element of transparency across the whole continuum. We used to call this sort of the episode, understanding the episode of care. But this one is getting into the very specific treatment activities. Next slide. So to close, the observations around at least the provider selection methodology is, this is from a transparency and putting the option in front of the member so they're in control to act on this information or not. I believe this is reasonable in terms of its approach. Looking in the back end, the contributions to those measures are reasonable clinically. For the average individual, obviously the performance score is a sort of aggregate of the calculations behind the scene. For those individuals that are more informed or do know something that matters to them, the good example is cancer care. The patients around cancer care know what to ask because they know very specifically the key determinants that will impact their outcomes. they have a concierge service that can help expose that and walk that member through as granular as they would like, is my understanding, the contributions to that score and why this provider is standing out. But obviously for simplicity at the app level, and I'm sure they'll go through that in the demos, just kind of rolled up, here's what's important, now go do your evaluation of that individual and the service that they provide. The other consideration, there is a score that's numeric, but I would be hard pressed to say that if you're a score of 90, you're 10% better than somebody with 80. I think it's fair to say, again, look to the Gartner folks to correct me, that if they're above this threshold, they're in that top quadrant. When you factor in the pluses and minuses of the analytics, I think that's more than reasonable. 100% doesn't mean you're twice as better as 50. I don't think it's a numeric calculation in that context. We would like to see more validity testing and bias testing, and that's something that they said they are going to be starting to do as more data comes in. But in the near term, they are in fact addressing the confounders, looking for any biases within the calculations themselves through that method. There's other parameters that are relevant that gets presented. So I just went over the performance score, but within the visualization, other things like distance, the review scores of their peers and other factors become sort of the qualitative parameters that go into preferences are factored in. So I think this is a reasonable approach to bring transparency and value-based choices in healthcare purchasing. Let me pause there. Any specific questions on some of the specific points?
I have another question, but I want to make sure everybody else has. I'm asking a lot of questions here, but let me just go ahead and ask my question. So can you tell me how this model for our member interacts with certain diagnoses that you want to get a second opinion on? Not because you want Gartner or not, doesn't matter. Just I want a second opinion on that diagnosis. How does this model work with that?
So I think second opinion, I'll jump in first and you guys can wait. Second opinion are specific to choices around, the most obvious one is like the key surgeries for musculoskeletal or oncology, where it is one point in that clinical journey that bifurcates into two different paths. In my view, once you sort of have clarity of which path, there's still efficiency, cost and value along that journey, right? So if I get a second opinion and really getting the elective knee replacement is the best recommendation for my clinical state. That being said, then where do I go for that surgery? Who is my surgeon? Because there's still a lot of clinical decision variability that happens after that.
I don't contact Gartner until I get my second opinion if I choose to want one.
So the way that I would describe it is that the member still retains freedom of choice. If they want to go out and get a second opinion, a third opinion, they could ultimately do that through the MODA or the Providence Network. They could come to Gartner to surface doctors that we would suggest for that second or third. We would continue through our financial incentive mechanism to reimburse members for that second opinion, that third opinion, up until that level of incentive is ultimately exhausted.
So I could use your service as a guide for my second opinion.
Absolutely.
Oh, okay, that's what I was unclear on. Okay. Robert.
So I've been withholding questions because I don't know if it's going to be addressed later, right? So I didn't want to gum things up. I do have a question. How is the steering to top providers, how would that impact access and wait times? Is that factored in, or how does that work?
Yeah, it's a great question. So that is part of our methodology and how we're making the recommendations is we're only recommending providers that we know have upcoming appointment availability, as well as are accepting new patients. So in addition to the quality and the cost metrics that we look at, as well as distance, we're always looking at availability for those providers. And so again, taking maybe Portland Metro as an example, there might be 400 different PCPs that we could recommend. We're going to recommend the top 20 from both a quality and a cost perspective that have upcoming appointment availability.
Yeah, so one of the things that's a bit unique about our data and our methodology is very unique, but one of the things that's very unique within that is that we are actually looking at claims data for those CPT codes that are associated with new patient bill visits. So there is actually a bill code for a new patient. So we're constantly monitoring those doctors that we're suggesting within the MODA and the Providence network. Are we still seeing evidence that that CPT code is coming through in the claims data? If it is, that means that there is upcoming availability for that doctor. And then once that slows down and ceases to be sent entirely, we would make an outbound outreach to that doctor's office to in fact confirm, are they now closed to new patients?
So is that methodology applied both to PCPs and specialists?
All types of doctors,
Okay.
correct.
And so Kurt, at that point, that provider who no longer has availability would essentially drop from the search results, right?
Yeah, we want to make sure that the member is having a good experience where they're able to book an appointment when we're surfacing a list of doctors to them.
So essentially, it's really a kind of cost, quality, distance to the provider and appointment availability. That's what's generating the list of top providers.
And yes, I would say the weighting towards cost, quality, and availability slightly higher than drive time, but yes, you're right.
Good questions. Next slide.
So that was a good segue, Kirk, with drive time, because that is what we are going to be talking about here in this next section. And so specifically, we're going to look at member access to Garner top providers based on where you live. And so obviously, both boards have a lot of interest and strong history in really advocating for members regardless of where they live. We know there are some issues with access more generally in rural parts of the state. And so this will be an important part of our analysis. And so with this slide, these are the access standards that MODA is using, which are those 5 columns in the middle of the table, and then the access standards that Garner applies on the far right. And so this is applicable for both OEB and PEB. There are different MODA networks between OEB and PEB, however, the standards don't change. But when we get to the actual results, we are going to split it out by OEB and PEB based on that different MODA network. And so the way to read this is those numbers in the tables are minutes to a brick and mortar provider. And so the standards, when they're determining access, will vary by a couple of factors. One is the geography type, whether you live in an urban setting, suburban, rural, critical access, county, et cetera. That is gonna vary the acceptable access standard for these 3 different provider categories, which is our second variable. So if you look on the far left, provider type, you can see primary care, high volume specialists, and subspecialists. And so similar to geography type, those are going to influence the standard. Primary care providers are seen more often. There's more of them than individual specialist types. And so the standard is a little bit higher, meaning that to meet the access standard, you need to have an in-network provider of that type within a shorter drive distance from where you live. And so generally speaking, the standards that MODA is using, the standards that Garner are using when determining access are pretty similar. One difference that I'll call out is that MODA does consider counties with critical access issues, which is that 5th column on the right, CEAC, counties with extreme access coordinations. Garner does not have a similar standard. Garner uses rural, and you can see if you sort of toggle back and forth between those 2 standards, there is a not insignificant difference, and so that'll play out in the results when we look at PEB and OEB member access to the Garner top providers in those rural areas. You'll see what I mean when we get there. Generally speaking, when you consider access for MODA versus access for Garner, it's sort of a qualitatively different thing in terms of how you interpret it. When it comes to MODA or Providence access, we're really talking about access to care, access to in-network care. With Garner access, we're talking about access to the incentive, access to these top providers. So whether or not PEB and OEB decide to implement Garner is not going to influence the sort of core access to in-network care that's available today through MODA and Providence. On the next slide, we have a similar table, but now we've swapped out MODA for Providence. The standards are very similar. So, you know, we were glad to see that both MODA Providence and Garner use similar standards. But again, I'll reiterate that when interpreting these results, when we get there in a couple of slides, the conclusions that you can draw are really different than when you look at general network access. These are really access to those top providers or access to the incentive.
So this will be another communication important nugget, because they still have access to care, but they may not have access to the Gartner network of top providers.
Yeah, and I would add that they have access, even if the access standard is not met. They might have to drive a little
Right,
further.
longer, but yeah.
And it's a great point. And a lot of those top providers have virtual capabilities too. And so that'll be an important part of the communication strategy should the boards, you know, decide to move forward with Gartner. And obviously, you know, virtual works in some situations and it doesn't in others. Sometimes the doctors will say, well, you need to be here in person. Other times maybe a follow-up can be done virtually. And any of those virtual visits with top providers would be eligible for the incentive. We want to jump to the next slide. This is just sort of a reference slide, and it's a quick comparison between the boards in terms of how is population distributed. And I apologize if that's kind of small on the screen, but you know, generally the distribution is pretty similar. PEB has more higher concentration of membership around Salem, you know, for obvious reasons, and then OEB sort of makes up for that by having slightly higher membership across the other remaining 6 regions. But membership for both boards is really, you know, across every county in the state. And so considering access for these, especially rural members, is going to be important. And so with that said, I think we can look at the results, and I'm going to apologize in advance because these are very data heavy. So if you get Rose, please jump to the next slide. We have color coded it, so hopefully the red kind of pops out for folks. Don't feel like you really need to read individual rows necessarily, although you're welcome to. I'll just sort of get you oriented here to how to interpret this. And so we're going to go through both boards and all carriers. We're going to show you results for all of these geography cuts. And so in the top left, we have included the percent and actual count of membership across each of these regions, just to give you a sense for how many folks we're potentially talking about. And so these percentages they represent the percent of members who have access based on those standards to a Gartner identified top provider. And so, for example, if you consider Willamette Valley, you can see that rural access for general family medicine is 98.7%, or sorry, 98.3%. And so what that means is that for those members who are living in those rural zip codes within the Willamette Valley, 98.3% of them have access, driving distance, to a general family practitioner within 45-minute drive from the standard. How we've color-coded these results is we've started to highlight in red. I think 97% was our cutoff. So anything under 97 is going to be very lightly colored in red, and that color will become more bold as that percentage goes down. We try to sort of draw your eye to potential access issues by high volume specialist or subspecialist or primary care. So if you look on the far right, you can see how we've categorized each of these rows, starting with primary care, a couple of rows for high volume specialists, and then the low volume subspecialists as well. So generally speaking, as you can see, these results are pretty good. Really high percentages. Where we are seeing some of that light red is probably not a surprise in our rural column. So generally speaking, really strong access to those top providers. Again, as a reminder, as we discussed, you know, the virtual capabilities are also eligible. Those claims that are incurred on a virtual basis are all eligible for the incentive, assuming that a top provider was the practicing physician. we're ready to jump to the next slide, we're going to see a little bit more red. And again, this is probably not a surprise for folks. We're now looking at the more rural geographies across the state. These are areas where we know that members are driving longer distances for care today, just when they're accessing the core network. And so this is sort of a reflection of a known issue around number of providers and concentration of providers in these very rural parts of the state. I'll also reiterate the comment I made at the beginning, which is that Garner is not considering counties with critical access considerations versus the MODA and Providence do, right? And so that's going to make it more difficult for them to meet the access standard in this rural column. Because if you consider the Southeast, a lot of the counties in the Southeast are in fact critical access counties. Generally for these rural areas, the more highly utilized provider types are more accessible. So if you look at the primary care rows at the top of each of these, they are a little bit higher than some of the specialists and subspecialists. Yeah, so I guess this is probably a good point to pause and get folks' reaction to these standards and these results, and any thoughts around supporting rural membership, should the forest decide to move forward with this program.
Andrew, I did have one question, is are the providers through, our carriers have used third-party vendors, and I'm using, say, Spring Health as an example. And are they considered part of the Garner network, those providers, even though they're not here, say, in Oregon?
So they are part of the core network. I think that Spring, for the most part, relies on virtual visits, per your comment. And so I don't think that they would show up in these results. Is that right, Kirk and Nick? Yeah, so they are not going to be present in these access.
So if someone uses, say, Spring Health and those providers, they couldn't get access to the incentive?
No, they could, because we have the flexibility with Garner to promote the vendor partnerships and point solutions within their app that we choose. So we could, for example, if somebody searches for an endocrinologist, we could highlight that we have Berta available, we could have Livongo available for behavioral health care, we could show Spring Health is available, Maru. So actually we're not talking about this as a pro of Garner, but in the back of our minds, we're thinking, wow, this is also another opportunity to educate our members about all of these point solutions we have available that they're not currently taking in.
And they could be considered part of that incentive that the member would have access to.
If there is an out-of-pocket expense associated with those. So I think many of those are free of charge to the member, right? So there wouldn't be a corresponding.
Well, true, thank you.
Yeah, so I guess, yeah, some would be more sort of promotional driving engagement, and then those like Spring, where there's out-of-pocket. Is my understanding correct that the individual providers within this sort of Spring sub-network, are they all listed individually in terms of their quality score?
Yeah, so what we would do is we'd highlight, so say someone searches for mental health, behavioral health, we would highlight Spring Health and drive people into that experience, as well as our recommendations down below, which do include virtual care. So kind of improving that access, allowing them to take advantage of Spring, as well as the behavioral health providers that are within network and that we would recommend.
In that structure, all of the Spring providers would be considered top providers. Is that understanding correctly?
We can have it set up that way, or we can have it set up more of the tile, go to any of the doctors. So is there, and maybe just apologize for not knowing the details on this, are there cost shares associated with Spring Health right now, or is that free of charge? Yeah, so we can configure it really depending on what the philosophy is at the end of the day.
Yeah, and that's what I was thinking, the virtual care, not so much the Bertas and those, because there is no cost to that.
Yeah, these results are really driving distance to a brick and mortar provider. Yeah. So to the extent that there's virtual access, those are not going to show here.
So, we've talked about this, with MODA and Kaiser, for that matter, on the access. So this reflects what we already know or roughly what we know with MODA and Kaiser. So what am I supposed to take from this slide?
So I would say that directionally, this is very similar to what we know about MODA, Kaiser, and Providence. But because Gartner's identifying a subset of the provider network, the results are going to differ a little bit. But many of the findings here are going to exactly match what we know about the existing motor network. For example, if you consider gastroenterology in the coast, this is one that we had talked about a little bit, right, Erica? That is a known issue within the broader network. And so it's also being reflected here.
And Robert, too, when we think about the access standards, we know we have our membership distributed differently across the state of Oregon. And we already know that we have different provider concentrations in certain areas. So some areas, the Southeast really stands out as there's just a general low access to providers. And we have 1.6% of the PEP membership there, and OEB would be similar, a little bit higher. But in the other areas, even let's say the coast, a couple of those specialties, dermatology, gastroenterology, a couple of those specialties have low access. But because this is an incentive on top of the core network, to me, what I'm looking for is, are there still other opportunities for members living on the coast for commonly sought services to have their cost share reimbursed? So there's still excellent access to mental health, OBGYN, oncology, and general family medicine. So other services members on the coast are accessing do have really high access, even though there are some subspecialties that can.
So follow-up question, so from the consumer side. So I'm seeing, let's say, I'm just going to choose dermatology on the coast, right? And so it's showing up that there's a real lack there. So when I'm going through Garner, will it only limit me to that 60, 75 miles? Or do I also have the ability to choose somebody that's 200 miles away?
You absolutely have that ability, yes. So you can,
it would pop up as a possibility.
so it's dependent on where you search, whether it's the zip code or its specific location. So you could broaden that search and say you want to look in a specific city that you're used to driving to, as well as contact our concierge team who would find the closest and highest quality approved and help you with scheduling on that appointment too.
Thanks.
And what the member may consider is the quality worth the effort, right? So that's hopefully that thought process.
Hi there, this is Misty, and this might not be the right time to ask this question, but when we're looking at 60 to 75 miles as the region of travel to meet these needs, I go back to why are we not having the option of Kaiser for a coastal region? Because I could get to a Kaiser provider within that mileage range. So I'm throwing that out there. I don't quite understand why Kaiser is not an option for these rural areas when we're already going to have to travel 60 to 75 miles for these other services anyway.
Because you have to be a Kaiser member to access Kaiser. So you do Kaiser for everything.
Yeah, I think, Misty, thank you for bringing that up. It's a really good question. I think we definitely would want to have the opportunity to be really thoughtful about that and talk more. I know we've had a conversation with Kaiser about that too in the past, and general drive times and really trying to set our members up for success. You know, but if it's a continued priority, please let us take that away and talk about that more with them.
It feels like an inequity. You know, as someone who's lived on the coast my entire life, I travel to Salem and Portland for healthcare and seek this stuff, and where I could have that whole wraparound Kaiser service available to me, I would access that 100%. So I just don't, I understand it's Kaiser's that it set those rules, but why?
Yeah, thanks. We understand for sure.
Any other questions or comments so far?
Pilotless drone taxis. With a free tranquilizer each way.
That's on the roadmap, I think, right? All right, so let's jump to the next slide. These next few slides, we're going to look at the other networks, starting with PEP Providence, and really the findings are very similar. And on the PEP side, the Providence and Moda networks are pretty similar. Where they differ is primarily in urban areas. As we've seen with these results, urban areas are really not the areas where, you know, there's less access to these top providers. It's really in the rural areas. And so we're going to see a same story here. So if you look at these first four regions, these are the less rural regions. Pretty good, 80s, mostly 90s, 100%. If we jump to the next slide, which are the rural areas, and again, this is now the Providence network, you're going to see almost the exact same amount of red. If we could jump to the next slide, please, Rose. almost the same story. So,
It's the way it is.
yeah. And when we get to OEB, which we can do now, we want to jump to the next slide, please. We are going to see very similar results again. And so again, MODA's network does differ between OEB and PEB. It's slightly broader for OEB. And so there are some regions where access to Garner top providers are a little bit better than what we saw when we looked at the PEB's MODA network. But again, same story, right? We're looking at these less rural areas. I don't think I see hardly any red, maybe two data points. And then as we move into the more rural areas, we see the red, and there's some repeats with regards to which specialty types have more difficult access for these top providers. If we could jump to the next slide, please.
Yeah, I mean, I think it's back to your point about this is reflective of the underlying network issues.
Yeah.
In these areas.
Yeah, totally. Yep. And one more slide, please. Yeah. So again, southeast, similar column of red, but the way that we've color coded these two is maybe a little bit extreme, because for many of these specialty types, we're seeing access in the 70s in rural southeast. That's not bad. That's the majority of folks do have access based on the standard for those specialties. It's not ideal, but it's reflective of a known issue regarding access across the state more generally. Okay, next slide, please, Rose. And so this is really just a summary slide. When MODA, Providence, and Garner are considering access, they have pretty similar standards. And again, when we look at Garner results, we're talking about access to the incentive. We're not talking about access to core care. Members in those rural areas are largely accustomed to driving long distances for care. And so the fact that they might need to do that for these Garner top providers is not inconsistent with what they're doing today. And then just wanted to reiterate the virtual piece, which, for folks who are comfortable using virtual care, accustomed to it, it's a great option in terms of sort of, cashing in on that incentive. So any questions or comments on any of those slides? Any surprises or kind of in line with what we know to be the case with the networks today? And oh,
Yeah,
yes.
they disappeared so fast. I was wondering if it was a mistake.
Okay. Any questions for virtual callers?
I'm going to interject myself here and call for a 10-minute break. Let's reconvene and start again at 10:40.
Sounds good. Thanks.
If you're looking for water, there's some in the break room over there in the fridge.
Let's dive into equity.
Next slide. Okay, this section here, there's 3 slides basically that we've taken the health equity framework and kind of overlaid it on the Garner program, and we'll go over some of the dimensions here and discuss as a group. Next slide. Okay, so in the review, we kind of looked at the 4 categories here: member experience, access, provider congruence, and then kind of summarize it under the methodology and the approach to sort of Garner's in context of the population with an equity lens. In terms of the member experience, again, the construct is this is it's a choice. It's not a forced program, providing a layer of transparency to inform the associates and members. In that context, the goal is to hopefully allow members to make that choice to go towards higher quality providers that we feel is a positive impact in terms of the translation of those choices to potentially downstream clinical outcomes benefit. Right? So from a member perspective, it is potentially reducing some of the unnecessary procedures, complications, and adverse effects of some of those treatment choices. There is potential for financial benefit for those member choices based on the incentive structure of going with the Garner top performer provider. In terms of access, the positives that we saw were the opportunity for, as an alternative to picking a provider on a directory A to Z, getting some additional dimensions and parameters in helping with those choices. From a provider congruence, there are some basic sort of search functionalities that support some individual level preferences, primarily around gender. There will be some expansion, or there is expansion for language search capabilities that will be sort of in place. And then the methodology, it is looking at currently 530 quality and cost quality metrics, in addition to the cost metrics that I outlined. It incorporates some of the CMS HEDIS type quality measures that we already are sort of tracking with the carriers, and the goal to sort of provide that holistic 360 perspective on providers in terms of quality and total cost. Next slide. Now, that being said, here's a list of some of the things that we feel are worth considering and are areas of opportunities that we sort of tabled and discussed with Garner around member experience. The important dependency is obviously knowledge, awareness, and then access of the Garner app. The app, in our mind, is relatively simple to sort of activate to get in line with the financial incentive. You just basically have to search for that condition or provider, and then the system will track whoever you go see to align those incentives. So I would say the basic step is before you start to get your next care appointment, just take a look at Garner. That's easy to say. So how do we get a large group of members to sort of align with that from a process perspective? Right? I need to have this looked at before I call to make an appointment. I look on this app, and just the process of looking at the list of top performers, there's the cookie crumbs behind there that if I go to see one of those top performers, the financial incentives are sort of a frictionless process behind the scene. Garner is going to work with carriers to address and hopefully optimize the education and awareness. Because this is so critical to plan design, and correct me if I'm wrong, this isn't going to follow the typical constraints of point solution marketing communication. So there's more flexibility here to really make this campaign around communication and member awareness critical. The limitations, so there's a concierge level service. So for any need beyond just the initial search results, there's a concierge service. The area of opportunity is obviously expanding those hours to ensure that our members, because of the nature of the work, there are access potentially or limitation to access to concierge if it's just an 8 a.m. to 8 p.m. Eastern Standard Time kind of a model. They Garner's acknowledged that, and it's something to be factored in. Language obviously is important to our members, given the diversity of the population. So that's another area that we feel is an opportunity to expand and meet the needs, the unique needs and the diversity of our population. With regards to access, for lack of a better summary, I don't think it's worse off than some of the issues that we know of and are aware of within our network. So any of our top performers is a subset of our provider network, but obviously there's still some underlying challenges for our members in that context. In terms of the timing or availability of appointments, there are some sort of threshold limits that are factored in by Garner. We feel that obviously not every need for medical services is immediate. So those thresholds on face value seem reasonable, but obviously the tighter we can ensure that those members get timely appointments when they need it for the conditions that they're seeking care, the better the member satisfaction, the better the timing in addressing the underlying healthcare needs and concerns. So right now it's sort of a 12-week sort of upper threshold. As a physician, I know my front office would always have the option of prioritizing, right? So even though there's a hard threshold, the reality is when you're making an appointment, hopefully there's some leeways amongst our provider community to get people in should they need a more timely appointment. But that's something that's hard to track and measure. So at the very least, we want to make sure the hard limits are there. And if we can improve on those limits to ensure access, the better. Provider congruence is an area that we hope for efforts to really ensure that our members can get that visibility, to get that congruence, to align the providers that they are seeking to their own personal needs and preferences. And it's at the minimum, it's race, ethnicity, LGBTQIA plus experience, and other member factors that they feel is important in their provider selection. Right now, obviously, in the absence of that full visibility of the app, the concierge would be sort of the go-to for the members to sort of triangulate to some of those insights around the providers that would be more congruent to the members' needs. With regards to the health provider methodology, again, it's I feel that this will be an evolving analytic capability and technology predicated on more data and experience, but also we acknowledge that and have spoken to Garner about sort of getting more insights related to social demographics, social determinants of health. Currently, they do not include the RealD data, but we would like to see RealD and SOGI data sort of become more factored in once we kind of figure ways to get that data collected and more accessible. So that's sort of the summary of the potential issues and areas of opportunity around health equity in regards to Garner. Questions on that?
I have a few. The service hours, especially the very Pacific hours, so you cannot get any service after 5 p.m. So that's gonna be.
We agree. And Garner, you want to speak to that?
Yes, and so we would have a designated pod for our concierge team that's focused specifically on state employees, OEB and PEB, and we would adjust those service hours to meet sort of the access standards that you're expecting, as well as specific training on the benefits that OEB and PEB members have access to. So that would be unique to the state.
That's great. And language line services, how many language are you thinking?
So currently, everything that we offer at Garner is fully translated into English and Spanish. So that includes the program, concierge team. We have English and Spanish speakers. Any communication materials, so written emails, posters, things like that that we're sending out to members can be translated into any language that we need. but we're willing to explore full translation into other languages as necessary.
And also now that you are gonna, in a way, creating a specific data collection, are you gonna use for race and ethnicity, the ethnicity like it's a typical, like Hispanic, no Hispanic, or are you gonna be more specific and collecting a specific and actually real data? Because that's so obsolete and it's from the, I think, Reagan, President Reagan was the one that created that, so it's in the 80s. So I don't know if you're exploring that idea to kind of update that data collection specific with an ethnicity, because Hispano or no Hispano is just, it's really a big pool and it's not really collecting real data.
Yeah, and you mean specifically for ethnicity of providers?
Yeah.
Yes. So that is currently something that we are working on expanding right now. Sort of the reason that we don't currently have it built in is simply the availability of that information. Not all providers are forthcoming with race and ethnicity. It's not always publicly available data. It's not in claims
No, but then when you admit a patient, you can, like a real surgery and all that, you can collect that data too, right? So, because all your strategy for the future, they're gonna base in the members. And then you're gonna put in the same bucket all the members when they have different ethnicity and race, right? You are already collecting the race because we have a pool of huge different races, but the ethnicity is not evolving since the 80s. That's my note there. And you are creating this, so you have this opportunity to be innovative in creating this. Just a note.
You're right, and I think we are committed to, and we have committed to working with the state as well as both MODA and Providence to make sure that the way that we're collecting that data and also displaying it to the member is innovative and updated as well.
That's it.
Any questions on that? No. Okay, the last sort of health equity dimension we briefly touched upon. Next slide, Rose, please. Is just, let me provide some clinical sort of perspective on the risk adjustment. Obviously, that's critical in terms of how we're looking at and measuring quality and outcomes. So currently, Gartner is incorporating the common factors in the risk adjustment. So accounting for these confounders, including gender, as well as some of the easily extrapolable social determinants of health from claims data. Through payer types, comorbidities, tobacco and alcohol use were the examples they provided. We are seeing that and have discussed that there's a need to, as data comes in and experience grows, to do some more internal bias testing. That's something that they have on their roadmap to ensure that metrics are measured in context of the patient panels that individuals are seeing, right? So each physician sees a different mix of population. So as we're analyzing their quality measures, we have to put it in the context of the population that they're seeing. I believe they're doing that now. The next level is to look for any biases within those subgroups for any variances there. So that's something that they're pursuing. For their feedback, they've purchased the race ethnicity data set to apply that analytics to some of the practice patterns that they're analyzing. I think this has been a challenging area for healthcare research. I would just say broadly, it's necessary, but you almost have to be very deliberate if you want to really tackle this. So in that context, I'm pleased to see that and hear that they are going to try to dive into that. Questions around this topic area? Okay, pass it to member experience.
Alrighty. So if we could, yes, thank you. One more slide, please. And so we're just going to walk through at a somewhat high level the member's experience of engaging with Gartner and the reimbursement process. And then afterwards, we are going to do a demo led by Gartner. And so that'll really sort of bring some of this to life. But I think this will be a good sort of teaser to get you thinking through how a member experiences this solution. So here are the 4 steps. And again, this is pretty high level, but we'll go through each of these in a little bit more detail in the next few slides. Starting off, members would engage with either the app or the concierge service to identify top providers. Once they've found a top provider, they'll visit the top provider, they'll pay their normal out-of-pocket costs at point of service. After that, the provider will bill, per usual, to Providence and MODA. Providence and MODA would then share that claims data, including member out-of-pocket costs, with Garner. Garner then behind the scenes will do their sort of crosswalk to see, all right, I got a claim from someone and they saw this provider, and I look over here and I see 2 weeks ago they searched for providers and I see this was one of the recommended ones. They do that behind the scenes and then submit the reimbursement to the member at that point for the out-of-pocket costs. And so we are going to go through each of these steps in a little bit more detail. So if we could jump to the next slide, please. All right. And so on the left are some comments talking about what it's like for a member who's using the app to engage with Garner. And then we'll talk about the concierge on the right as well. And so there are some different ways that the member can search when they're using the app by specialty, symptoms, condition, procedure, provider name. There are some other criteria that we'll look at in the demo that are in addition to these in terms of how you can filter results, including distance and that kind of thing. Once you have the results, you can, to the extent that you're interested, you can look into a little bit more of the detail behind the search results in terms of specific providers, why they scored what they scored. You can look at patient feedback for others who've seen those providers, as well as some other information that's going to be relevant for some members. For those who are engaging with the concierge, this could come in the form of a phone call. It could also be an email. It could also be chat through the app. The concierge can provide a similar search to what's done on the app, but it can also do more. It can help with specific questions around provider congruence, provider-patient congruence, and helping members who maybe have a somewhat more unique need that the search results on the app aren't sort of readily displaying for them. And so all of these, so let's jump to the next slide, please. All the member has to do is search or talk with concierge. At that point, Garner will be tracking those search results behind the scenes. And so from a member's perspective, you complete the search. Okay, here's a cardiologist that looks good as a top provider. You schedule your appointment, you go and have your services. And that's really, from a member's perspective, that's all you need to do. Garner is tracking and making that connection behind the scenes to ensure when they get that claims data, there's a claim for Andrew, it's a cardiologist, I see he did a search and saw one of the top providers, and that's all something that happens behind the scenes. So that's pretty member friendly. They don't need to indicate to Garner that they've seen that provider or mark them in some way. And so at that point, the member will go and see this provider. Again, they pay their sort of normal out-of-pocket cost share based on the plan design. And it will be later that they will get reimbursed by Garner after the fact through that health reimbursement account.
Quick question, so if you're at a GP and they're referring you to a specialty provider, does the GP have access to see what's recommended?
They do not. Yeah, and if that GP makes the referral, does Garner track that via claims and consider the second provider? No.
Yeah, every episode is independent of one another. So if a general practitioner that was Garner recommended would refer somebody out for a dermatologist or a cardiologist, there would be an expectation that the member would either use the concierge or the search tool to find that cardiologist or that dermatologist. One of the metrics that we do use for ranking and identifying top performing primary care doctors is their referral patterns to high performing doctors, but it does still necessitate the member to take action when they need to go see a specialist.
Some of those savvy users, maybe they have the app up when they're with their PCP talking about a referral, but that's not going to be all members, of course. But
so I have a question. It's probably more directed at MODA, but so along those lines, we're looking at potential cost savings with this. That's part of the afternoon session as well. if I'm a current MODA person, right, and I already have my primary care, so I'm not changing my primary care, how will I know to use Garner and not the primary care's referral necessarily? So if we're going to capture savings, then we need to get people to use Garner, and I don't know what that plan looks like if they're going through their primary care provider for suggestions.
I think a lot of the opportunities will be new episodes of care, but you're right. Not all primary care providers are going to be identified top providers. There is an option to potentially flag all primary care providers that are in network today being utilized as top providers. We can talk about that a little bit. That would potentially eat into some of the savings, but if you just indicated all existing in network PCPs who are being seen today, we're going to consider them top providers, sort of prevent disrupting that relationship. Because otherwise, in your scenario, if you're seeing your PCP, they're not one of the top identified providers, now you have a sort of fork in the road. Do I continue with this person who I have a relationship with and know my health history? Or do I go to Garner and that incentive is really appealing to me, and so now I'm going to actually change primary care providers?
I was actually thinking more on the specialist line. I'm getting referral for a specialist. And my primary care provider said, go to this person. Garner has a top provider, but how do I know as just the person that I should go on Garner when my primary care provider has said, go this way?
And part of that is really the communications plan. I mean, you kind of hit the crux of it, Robert. It really is, helping people understand that they have an option when they're starting a new episode of care, to go with the top provider or to go with the person that's reflected by their PCP. If they go with the person, that their PCP is referring to, they're no worse off, right? Because the benefit is the same. But if they go to the top provider, there's an incentive. So I think that's part of the key challenge is how to kind of make sure people have that information when they need it.
Yeah, to Kimberly's point earlier, it's a habit that we're going to try to cultivate in our membership, which is every time you need to initiate care, you're in the habit of opening the Garner app and searching for care. And that's all you have to do in the Garner app is search for care, for that type of care that you need. And all the top providers are flagged. You can go to one or not. But we want to create this habit through marketing, and Garner's been working on a marketing communication plan behind the scenes that really considers all the nuances of OEB and PEB's membership, the entities and the agencies also. So we'll be messaging to members about the app and the concierge and really encouraging people every time you need care, use Garner.
So I guess this is the motive question on this is, as far as, the communications plan and, getting people to use it plan, how invested is MODA going to be on integrating that into their system, or is it going to continue being separate? I'm not saying it correctly, but hopefully.
I want to answer this a little bit. Robert, first off, those are great questions. And I do agree with what Mercer's saying. It is going to be a behavior change. We're asking members to do something different from the way they do it today. And so it's going to take a lot of communication. And in addition to the communication plan that Garner's doing, we'll be partnering very closely with OEB and PEB on the communications around this as well. And we will be integrating Garner into our system that we have already. So within our MODA 360 platform, again, as I said before, one of our goals is to have every door be the right door and then also one single door. So we'll be integrating the Garner app into our MODA 360 app. So members can just go right into the MODA 360 app and hit Garner, and it can be that experience, so the experience they're already used to doing, or they can go in through just the Garner app too. And we'll be integrating it into all of our systems inside. So as soon as they come into the dashboard, they're going to see Garner. If they go to our websites, they're going to see Garner. If they look at any of our marketing materials, they're going to see Garner. And then in addition, we'll be training our health navigators with Garner, because we're really going to have to be working on some more handoffs, because our navigator team is going to be working very closely with Garner. And there are going to be times when we're going to need a warm handoff off to Garner, or Garner's going to want a warm handoff back to our MODA Health Navigator team. So we need to ensure that we have processes to make that seamless for members, so that they're not having to go, okay, where do I go? Do I go to Garner? Do I go to MODA? It should be any way it's right for the member to go. and they shouldn't have to be asking the questions, but we should be directing them to where they need to go. In addition to that, the other thing I want to say is in addition to all of the other communications we talked about, we're also going to be sending communications to our providers so that it's not a surprise to them. So when members are in the office, you know, and they may be like, sometimes, you know, providers will be like, oh, where do you want to go for this specialist? Then at that point, the provider's not going to be surprised when the member's pulling up their Garner app and asking for a referral to this provider.
Thanks, that helps.
Okay, I stand.
Go ahead, Ali.
I was just going to say, yeah, I mean, I think, you know, we've got long partnerships with OF or with NODA and Kaiser of, you know, it's always separate communications, but it's always together. I think we work really closely and have gone through, you know, basically change management kinds of initiatives to get members to the point of acceptance and make it part of the norm. I think this is a self-empowerment tool to help members advocate for their own health, which is something that we've talked about for a long time in this committee. You know, I think leveraging the OEB consultant committee and our partners there will also be a big benefit to getting the word out to where it needs to get to and supporting our members.
And I would assume Garner is going to assist in with the communication, so you know, based on their experience.
Just to add to Ali's point, I think that's the key is it's helping our members become sort of healthy curious in terms of their care, and to be comfortable having that conversation with the provider. Historically, we're referring to our colleagues either because we went to the same residency together, same med school, right? So asking them, well, what is your basis for referring me to that orthopedic surgeon versus having something quantitative and having that dialogue and say, well, what's your basis for recommending that person? Here's some data points, help me reconcile the two. So it is empowerment, it is the communication dialogue. It's supposed to be a joint clinical decision-making between the provider and the patient ultimately, but helping that member get comfortable doing that, I think, is a journey. So,
and I would say that on the Providence side, similarly, there's existing infrastructure and navigation services, and so the type of integration that was described is also going to apply on the Providence plan. Is that fair to say?
That is correct. And similar to what Erica said, we will be undergoing similar infrastructural changes for us to elevate and ensure that PEB members have access to that at the top of their Get Care tool when they log in, and they can find that within the directory. So it's prominent there at the top. We're also investing in some new applications that will be available to PEB members this fall. So that experience, along with some single sign-on work that we're working with Garner right now to see if there's a way in which to ensure that there is a single point of entry for people to get in, so they're not having to go to multiple places. But similarly, our navigators and our advocates will be directing people to Garner as well.
Thanks, Cash. Yeah, and integration will be key for sure. So I think in the interest of time, we might want to jump to the demo. We've got about 20 minutes remaining in this meeting. So does that sound good, Kirk and Nick?
Absolutely.
Okay.
Well, and Andrew, I would just say we can go till noon.
Yeah, we can keep going. We can keep going? Okay. All right. I got a couple more slides then. So I will buy Kirk and Nick, I'll buy you guys a couple of minutes here. So on the billing and claims step, this is actually one that's not really part of the member experience per se, because this happens behind the scenes. And so this is the process whereby MODA and Providence would share those paid claims data with Garner, as well as the out-of-pocket cost, so that Garner can do their tracking behind the scenes and see which of those expenses are eligible for that reimbursement, which brings us to step 4, which is the distribution of that reimbursement. Next slide, please, Rose. So when it comes to receiving the reimbursement, there's a couple of options, one of which is a direct deposit. If you, as a member, had set that up and entered that bank account information into Garner. Otherwise, you will receive a paper check. And so after the claims are processed, that's when the member reimbursement would be reviewed and approved. So there's still going to be sort of the normal claims lag that occurs today in medical and pharmacy, right? The period of time that occurs between when a claim is incurred and when it's finally paid. But after it's been paid, members will receive their reimbursement. I think the timing is 3 days, is it, after claims been paid? Is that right?
It depends on the specialty, but yeah, it's a very quick reimbursement.
Okay, great. Thanks. There is some functionality on the app where as a member, you actually have line of sight into your past reimbursements, kind of nice. Yeah, so I think we can jump to the next slide. And this one covers a topic that we've talked about, which is this ability to promote other sort of solutions within the sort of benefits ecosystem. And so the example we're using here is Verta. Verta is a solution that doesn't have any member out-of-pocket costs. And so this is not a reimbursable provider per se. This is more of like, hey, you search for an endocrinologist. Did you know? You also have this other solution available to you. And so it's just sort of trying to create awareness and driving engagement into those point solutions, which, you know, per our behavioral health point solution analyses we've been doing, like that's really sort of the name of the game is driving engagement into those solutions so that they're used and so that, you know, value is produced from those. So let's jump to the next slide. I think we can do this one pretty quickly because it sort of reiterates some of the things that we've already talked about. One of which is the learning curve. So the reality that there's sort of be like this momentum building period and trying to ingrain this new habit in members, which will take some time. So of course, communication is going to be really important. Integration within the existing solutions is important. And so there would be a lot of work on those fronts, you know, should the boards decide to implement. For members who are already using a top provider, they would need to either go into the app and search for that provider or call into the concierge and say, hey, I'm already seeing this person, at which point Gartner will become aware and the reimbursements will flow on the back end. Certain services that are ordered by sort of by ancillary providers they don't show a quality ranking because there's no member choice in it. So think like anesthesiologists or anesthetists or like radiologists, like that's not something that the member goes and, you know, if you're having a surgery, you don't have any say on who's providing the drugs from the anesthesiologist. And so those providers, claims associated with those providers are eligible for the reimbursement, correct? Yeah. So those are
part of that total episode of care.
Yeah,
exactly. Okay.
That makes sense. Yeah, I think those were the key points on this slide. So I think at this point we can probably shift over. If we're ready to do the demo, we will hand it over to you both.
All right. Well, thank you again to the boards and the SEOW for allowing us to sit in and to provide a bit of a user experience here. Feel free to jump in, ask questions as I'm going throughout, but just wanted this to reflect what an OEB or PEB member would experience in utilizing Gartner here. So again, multiple different doorways in order to get to this screen. This is obviously going to be the same exact experience, whether I'm on my computer or whether I'm on my phone with the Gartner app. And again, whether I'm getting here from Moda or directly utilizing Gartner or Providence, this is going to be the experience that I see. So first and foremost, you notice we want this to be very clean, simple. We want there just to be a few things that we're directing members to do. We don't want this to be overwhelming. Obviously, being a dummy demo account here, the first thing that I'm seeing is setting up direct deposit. This is going to be one of the first things that people see when they log in for the first time. Very easy experience here. And that speaks to us wanting to make this very non-disruptive for that member and an automatic process. But I'll start with where most of our searches start here, within the self-service tool to find a provider. And I know, especially for the people in the back, a bit of an eye chart here. So I'll kind of call out what we're doing. But we can search for any provider name. So to Andrew's question, you know, maybe there's a primary care provider that I want to see if they're considered Gartner recommended. I can look for a specialty, say I need a cardiologist. We also know that oftentimes members don't necessarily know the specialist that they're looking for. We use natural language processing. So if someone says, hey, my back is killing me, I'm in Portland, I need to find a provider as soon as possible. We want to drive as much care as possible to primary care physicians. So we're asking first and foremost whether they've seen a PCP, especially for something like, hey, I have a stomach ache or my back hurts. But what's going to come up is a list of providers that follow a few different rules. So first and foremost, all of these providers that we are recommending and that show up in this search are going to be within network. So understanding the underlying plan design, the network that this particular member has access to, we're never surfacing out of network recommendations. Next, you'll notice that we've got about 15 to 20 different recommendations here, all with different associated scores. All of these providers are Garner recommended. All I have to do as that member is perform this search. I can go see any one of these doctors, and then I get reimbursed for every single one of my out-of-pocket expenses up to that incentive amount. So that includes that office visit, prescriptions, imaging, surgery, whatever, as long as I'm seeing one of our Garner recommended providers here. Yes.
So if my chiropractor is not recommended, it's not part of my network, you're saying I won't be able to find it, although I'm okay with paying the additional fee or the extra process fee that I have to incur because I'm going out of network?
So you would still use your medical benefits as normal. So it would be part of the underlying network. We're not taking anything away. But if that provider that you're looking for specifically is not recommended within Garner, you just wouldn't get access to that incentive.
Enrique, one of the things that we talked about earlier on this morning was that the core networks still stay in place, so there's no change to the medical network. This is really just talking about if you want to have your out-of-pocket costs reimbursed, that's what we mean by the incentive, then there's a subset of providers that you could go see who are higher quality, lower cost and get reimbursed for those, but you're always free to continue to see who you want at your normal cost share.
Yeah, I appreciate that clarification because I was listening in the morning earlier online, and I guess for me, it goes back to what Erica was saying when Robert asked the question that we will do a warm handoff where the communication needs to be clear. Because if I represent 42,000 members, and if you were to say, if your provider is not here, is not with the network, you're not going to see it, then automatically it's going to trigger like, well, then what am I doing this for? So what I'd recommend is to copy paste what she just said to, you see, I guess the communication piece is
absolutely.
I think that's what Robert was trying to say earlier, like, well, how is Moda going to support this and their system? So I appreciate if maybe, I know this is just a demo, but we have to have our language in sync because I can hear a lot of members asking what I just asked, although it was covered earlier. That's all. Thank you.
Thanks, Mike.
I think that's really important, and that is part of the way that we display this information for the member too. So we can see here that this is in network and approved for your Garner benefit for this particular provider. Say if I had done a search for a provider that is not Garner approved, the information that we're going to display is that they are not approved for your Garner benefit, not necessarily that they aren't within network. So that would be the message to employees and members. But the last criteria here, so obviously we're looking specifically within Portland. We don't want people driving more than that acceptable threshold for that geo access. But all of these providers we know are accepting new patients and have upcoming appointment availability as well. So that when I click in and let's say Dr. Chris is close to where I live, for that member, I can read a little bit more information about our methodology. We can actually go very deep into why we are recommending this particular provider from both a quality and a cost perspective here. Giving information about some of those data points that we utilize in order to make those recommendations. We do take into consideration publicly available patient reviews, but the majority of why we are recommending this particular provider is because of all of those 530 metrics that Dr. Chung and John were talking about earlier. So everything around their practicing patterns and actually where they're practicing medicine too. Yes, Dr. Laura.
Can you show us one that have a lower score, please?
One that has, sorry?
Lower score.
Well, the providers who are not top providers aren't going to show up in the search results.
Well, a 92 then.
Sure thing. So all of those quality metrics really bucket up into these three areas on diagnosis, treatment, and outcomes. So all of these providers are what we would consider top providers, kind of in that top 20 to 25% compared to their peers and their practicing patterns.
And when we say peers, it's a relative peer comparison. So it's not ever comparing doctors in Bend, Oregon to doctors in metropolitan New York. It really is peer to peer within like geographies as well.
So those clarifications they need to be also communicated, because if I don't know anything, I'm going to go for the higher, and then I'm not going to choose my necessity doctor just because the number, right?
And I think in this, we're looking at the specific episode of care or healthcare intervention that this particular member would need. So we had searched for back pain. Dr. Riggert is a non-surgical orthopedist. We might be surfacing a different non-surgical orthopedist if I had searched for knee pain or shoulder pain. So for that particular episode of care here. We're displaying information about languages, specialties, location, and then again, because we know that this provider is accepting new patients, has upcoming appointment availability, when I call the schedule, I know that I can actually make that appointment in time. So the other thing that I think is really important to call out is how we could fit within the full ecosystem here and surface recommendations like Virta Health, like Spring Health. So for instance, here at Garner, again, this being a dummy data account, we have access to Bend Health for pediatric mental health. You can see that when I search for that applicable term, Bend Health comes up first and foremost. We can drive people into that experience, as well as our recommendations down below. And you'll see that specifically for therapists here, we do have the option to book online, and we're highlighting those therapists that are accepting virtual appointments. Now, the other thing that I want to be very clear to focus on is our concierge team. They are fantastic. These are all Garner employees. They are US based, they're English and Spanish speaking, and they're here to really help members for any sort of search or any type of care that they're looking for. So I can message in directly to the concierge team. We have a dedicated phone line that people will have so that they can call in, get those questions answered. But you can think of this as kind of that white glove experience for finding the right provider for that particular episode of care that you're looking for. So this particular example, this was real example, was looking for a provider for my wife. The doctor that I had gotten as a recommendation from a friend, I had the concierge team check. It looks like that particular provider was actually not considered a Garner recommended doctor. And so what they were able to do was find me 3 other recommendations that, again, were Garner recommended, so could be completely reimbursed for my out-of-pocket expenses, as well as had upcoming appointment availability within the next week. So very common, actually just our colleague a couple weeks ago, and I believe Mercer team, I've shared this example with you, needed to find a pediatrician for his daughter. Needed to be Wednesday or Thursday of next week, because that's only what fit with their schedule. So reached out to the concierge team and they were able to find 5 different recommendations that not only were covered under that benefit, but also had that availability.
I think I was going to actually just refer back to one of your use cases about there's somebody that had something that was more rare, like, hey, my spouse was just diagnosed with a rare glioblastoma. I want to make sure I'm going to like one of the top doctors in the country for this. That's in my network. That's really where our concierge team could actually dive into our clinical data with our clinical leadership team to identify the doctors that focus on that particular form of glioblastoma, have the most experience with those procedures and the best outcomes at the same time too. So again, we're not trying to over inundate a member with a lot of complex metrics and data, but in those really serious and complex situations, we have the benefit of being able to actually grab that information from our data set and really provide that type of information to the members as well.
Does the member have to repeat the search for each episode of care?
No. So for each individual episode of care, yes. But if it's the same provider that I'm going to, I just need to search for that provider once, and then they're automatically pinned to my account in perpetuity.
Okay, so you could see him in January and then have a relapse in September and
Exactly.
Okay.
So I found my PCP through Garner, saw her once at the beginning of the year. I have prescriptions that I pick up every single month, and the cost of that prescription is refunded to me or reimbursed automatically. I only have to perform that one search and see her one time.
Nick, will your concierge be dedicated to OWEB and PEB full time, or are they sort of applicable?
Yes, so right now we're considering 2 different options. One, our concierge team growing very quickly, so we either could have a designated pod that the majority of their time would be spent on PEB and OWEB, but regardless of whether or not it's dedicated or designated, they would undergo specific training to the state, any other sensitivity trainings that are required, as well as just understanding the benefits that members have available to them so that there can be that warm handoff.
Let me flip the scenario just because it popped in my head and maybe I should have asked this earlier. But let's take the scenario where Ian sees me at the bar on Friday night and taps me on the shoulder and says, dude, I tried to recommend you, but you suck because you weren't on Garner's list. Okay, and I'm like, oh shit. So Monday I call Garner and say, hey, what's up and how do I improve? What do I need to do? Do you have that service to improve the general healthcare in our area?
Yeah, and that's, do you want?
Yeah, I was gonna say, we try not to, what we don't want is like every doctor that we're not recommending to call us, as you can imagine. I would say our bigger mission in life, as it relates to Garner, is upping the game of all healthcare across the country. So what the ultimate goal is that we are potentially disrupting some physicians because their metrics are not in line with what we would expect to be that of high quality, low cost. If you kind of think back to that sort of chart that Dr. Trang had up earlier, that top quadrant, and then really help them understand what do they need to improve on, whether it's their clinical behaviors, whether it's outcomes, whether it's where they're steering different sites of care for different types of procedures, so that at the end of the day, like all healthcare improves across the country, and in this case, within the state as well too.
I would say even if you, like if I'm a provider, I'm saying, okay, I'll pay you $100, send me a report on, I don't even need to talk to you, just send me the report on how you evaluated me, and I can look at that and say, oh.
Most doctors don't know, like they can't, first of all, they can't pay to be part of our recommendation, like we are neutral that way, but to the extent that doctors or physician groups or hospitals are interested, we could support those on a one-off basis. And then we also have systems that are customers of ours that actually use that data to help improve their own learning and development programs within their own provider practices too.
And then the second question I have, are you done here? Should I?
Sure.
Okay, good. I didn't want to, I just realized that. So this is just a general question that I have to ask of everybody, right? So your customer is Moda and Providence. What in your contract is commitment to them as our members, that our data from our members is secure, private, only to be used inside your company, or rolled up to where it's no longer personally identifiable? What is that commitment?
Yeah, so we're in active subcontracting conversations right now with both Providence and Moda. So that specifically for us, we are SOC 2 Type 2 certified, high trust certification. We take data security very seriously, given the sensitive nature of our data set. So we de-identify information that we utilize in order to make those recommendations. So we're happy to provide you with the specific language of what that would look like too.
Can I ask a question about coordination with PCP 360? I think it's another communication piece, because we've been out there, go PCP 360, get referrals within your thing. It's more efficient. Now we're putting another layer on top. So plans around, what does that look like?
That's a great question. And I'm still working out the exact details on the PCP 360 and how that will be handled. But the PCP 360 will still be in place. And so we will still be encouraging members to, pick a PCP 360 for OA. That means they get the coordinated care benefit level.
Right.
For PEB, it's a requirement that they see their PCP 360. And so we will be proposing to you guys what we think we should do around PCP 360.
Yeah, if they have internal referrals, that will be supported.
Yeah, and the referral part will work just like we had discussed before.
Okay.
Where yes, the PCP makes the referral, but they will be using Garner for that most efficient referral.
Oh, okay.
The providers will not. Sorry, the members will be.
The member will be. So I go to my PCP 360. They refer me. I can go there, or I can check Garner and get referred.
Correct. Yes.
I have a question. I'm wondering if you can comment on, so the tool returns the top 20 providers in a search, and I'm wondering if you have any insight or observations on like the degree of retention there is in that list of top 20. I'm just thinking about, like, you take a pretty common search, something like, I need a primary care provider in Portland Metro. And if those top 20 providers that come up continue to be the same one, like they're going to get full pretty quick, I would guess. And so then, like, I imagine as their appointment availability decreases, different providers get refreshed into that top 20. I mean, can you offer some kind of context around, like, is that how that works?
That's exactly right. That's exactly right. Yeah.
And is there anything else other than just the appointment availability? Because there's a little bit of a lag on that. Like a provider I can look in my app now, and my primary care doctor can have 10 appointments available next week. And then I look in the app later tonight and she's got nothing for a month. And so like that availability is very fluid. So I'm curious as to like how that's managed.
Yeah, so we receive claims data on a monthly basis. There will always be some element of staleness, to your point. If the doctor suddenly retired or whatever the case might be, like that data might be stale for a couple of weeks until we have that refresh of claim data as well. To your point though, so just to kind of go back to the initial part of your question, we are typically surfacing somewhere between 15 and 20 as one of those doctors does end up not being in the network anymore, or for whatever reason, they might ultimately drop out of our recommendation. Most typically it's due to a doctor potentially being acquired by like a higher cost health system, and suddenly their unit cost is a lot more expensive, and that might ultimately remove them from our list. Otherwise, we have a very stable, the metrics that we use end up actually being very stable from month to month in terms of doctors staying in. But ultimately, I lost my train of thought there for a second. So we are always going to be surfacing, again, 15 to 20. We are going to be monitoring appointment availability. There will be some element of staleness until we reset that data on a month-to-month basis. Our concierge team will always be an opportunity for a member to go out and actually have that human-to-human conversation, whether it's telephonically or through chat, to have the concierge actually do the legwork to find people that have appointment availability too.
Yeah.
I don't know if you have anything else to add to that.
Yeah, if there's, so the example that I gave before with our colleague looking for very specific timing for his daughter with the pediatrician, we'd always recommend contact the concierge if there is that restriction that you have in place and you really need to get seen within time frame. But otherwise, the way that our system works with the self-service is exactly what Kirk described, where we're only surfacing those doctors that we would recommend from cost and quality that we know have availability to.
And well, I guess one other, and this is an observation, I guess, more than a question, but again, I don't know if you have context on it, but just kind of thinking about like, and I'm using Portland Metro here as an example, just because it's where I live and I have the most familiarity with that, but like just thinking about like I noticed on the search where you did for pediatric mental health providers, and it popped up the list, and it looked like, just from what I saw on the geography, it looked like they were all on the west side. And I'm just thinking about like, you know, if you're a member on Southeast 182nd Avenue and you've potentially got to get your child to a mental health provider that's across the river to get an incentive, and maybe like if you have to rely on public transportation or something specifically to do that, that's no small feat. So I just want to flag that, like, I think even within an urban area, if we say, oh, it's only 15 miles distance or 10 miles, like there are community nuances, like the west side of Portland, very different from the east side of Portland in some respects. And so I just want to flag that, because like, just looking at that example, that could potentially be a real hardship for some people to reach one of those providers.
Understood.
I think it's a point to add to our list of marketing considerations, Margaret, because the member could always in that situation reach out and have a live conversation with the concierge to then get more specific about the location of who they're going to see and try to refine that list to be closer. They would need to know that that's an option for them. So then I think it comes back to the communication.
For sure, and certainly seeing any network provider is an option for them, but seeing a Garner incentivized provider is the next layer on top of that. So I just, again, I don't think it's like, it's not a question, but it's just an observation.
And he also, if he searched broadly for Portland, Oregon, we could actually search by 97211 as well. So there's zip code based searches as well. So that would ultimately vary the radius of where that number is. We're looking at a very broad geolocation right now.
Okay.
Portland.
And I'd also say, again, this is based on not the MODA or Providence network here for this demo account. This is based on a different network. So if we're not seeing the results that we would expect, that's a possibility for why we're seeing that.
Okay.
You can
start to
surfing.
see some east side documents at that point now too.
So I think that that's going to be important for members to understand too, is that if they can be as specific as possible about their location, they are in a better position to identify providers that are closer.
That's correct.
I think the other thing too to note is that, you know, it's not that they're changing their threshold above which, you know, in terms of who's a top provider either. I think that's the other thing to note. There's still a bottom threshold of which, you know, all top providers have to be.
Are there any other questions on the user experience here? Happy to dig into any other portion, but hopefully you saw quick demo because we really want this to be straightforward for members.
I'm gonna recommend we get on these last two slides and then the board discuss each, what we can do here. Right. Somebody want to cover these last two slides, or
I'll
is it?
just cover them, I was waiting for them to be displayed.
Oh, Rose, if we can bring up slide slide 57.
Here we go. So again, I think on balance, Mercer, it recommends that the boards consider Garner for the next plan year. Our key rationale really is that this is an innovative approach that helps the boards achieve their goals of, delivering higher quality and lower cost care to their members, and also mediating some of the out-of-pocket costs for members as well. I think the key thing, and a lot of this has come up in the discussion today, the key thing to remember is that this is an incentive, it's a carrot. If people decide not to use Garner, they're no worse off in terms of their benefit levels. So I think that's something that's kind of attractive to us. And also that there's very real possibility. So to the extent that Garner is able to encourage people to use low-cost providers on a sustained basis and on an increasing basis, it should help bend the trend going forward. And that means, decreasing the need for plan design changes and subsidization going forward. And we're not saying that Garner is perfect. I think we've had a lot of good discussion in terms of some of the challenges. But on balance, I think it represents one of those rare win-wins in healthcare where it benefits both the members and the plans. And if there are things like Dr. Laura identified the service service hours. That's something that can be brought up in the contracting between MODA and Providence. That's a requirement in the contract and things like that. So if there are things for the board that are particularly important, some of those could be addressed in the contracting process. I think if a decision is made to proceed with Garner, we would also encourage very close monitoring, especially in the early months, just to understand where are the disconnects coming with members, so those can be addressed through communications and other means. The other thing too is really taking a deeper dive into the access to top providers, be it geographical access, wait time access, or capacity, as Margaret was bringing up, just to really understand those things going forward. And again, understand those across a range of specialists.
Yeah, I think, last fall as an OF board, just speaking for the OF board, we set new goals collectively, and 3 of those goals include member education. We have reduced out-of-pocket costs. We also voted as a board to increase access to high-quality, affordable care. I believe that maybe with few exceptions, our members actually want to know who is the best, most affordable doctor, because they ultimately are the ones who benefit from the better outcomes and the lower cost. And today, what they have is maybe referrals from friends or their current doctor, or maybe you can Google. None of those pieces of information include anything about cost. And the quality portion of that is anecdotal, if present at all. Google doesn't really talk about outcomes at all, right? It's just the people who chose to leave a review, what did they happen to think, and it's a very small sample. So here we have a tool, and Ollie called it a self-empowerment tool. Dr. Chuang referred to it as a transparency tool. So now we have a tool that comes in and provides the information that leads to member education. So now at least our members have a choice. Even if they choose not to use the Garner provider, we're at least giving them the information so that they can use a choice. And the truth is, as we're going to see this afternoon in the OL board meeting, claims trends for many reasons, higher unit cost on services, more services, higher acuity services. Trends are high, and our round 3 renewal increase is actually higher than round 2 because the claims is trending that high. So then when we think about Garner, and what Garner does is it says, hey, Not all providers have the same quality. Not all providers have the same cost. In fact, the lower cost providers who are of equivalent quality are on average 24% cheaper than the higher cost providers. So now we have an opportunity to come in without compromising quality and without changing benefits. We have an opportunity to get 24% reduction on those episodes of care with those top providers. Fits right in with our balanced framework of negotiation efficiency. This is all about efficiency, saving subsidy and benefit changes for last. So given the communication challenges that we've talked about, maybe some existing rural access challenges that Garner doesn't fix, we know are still there. It really achieves so many of the board goals and our overall renewal mission to this year. It's an important part of the overall package to think about.
I'll chime in with, a different perspective on exactly what Kirsten is saying here, that from both boards, right? A change like this is going to require both for our members a learning curve and an utilization curve. There's not going to be an instantaneous jump next October. It's going to take some time to roll this in, and we may not get the numbers next year, and I won't be here for that. You all will. But just know that this is a learning curve that's going to go on here. It's going to get better. It's kind of like BH60 and things like that, where it takes some time for members to really, okay, I see what we're doing here, and to adopt it and to accept it, right? As okay, I get this is helping me. So understand that there is a growth curve that's going to occur, right? And that it takes some time. You're just not going to get a decision, in 6 months and say, right? You can make it a commitment here for some time. Does that make sense?
And this solution is unique too, and that it comes with a financial incentive, which our other point solutions don't. So that should change the engagement levels.
Again, the carrot versus the stick, right?
I could just add one thing that really stuck out to me that gives me some peace of mind, speaking for staff, is if Garner does have a concierge team that's actually specific to PEB and OWEB and could be trained on our plans, to me that would be really beneficial for helping members and some of the hassle.
Oh, this is Andy, if I can make a comment.
Sure.
So my question is, especially for PEB, and I don't know if OEB's on the same thing, so this would be in place for the next year until we had the RFP done. Is that correct?
So that's right, Andrea. Yeah, this would be 1/1/26 go live if the PEB board approves it. 1/1/27 will be the effective date for whichever bidders are awarded the business coming out of the medical and pharmacy RFP. So there is the potential for this to be a one-year solution. That is one potential outcome. However, I will say that a lot of the goals and things that this solution tries to target in terms of what they accomplish align with a lot of what we're trying to accomplish through the RFP.
Right.
And so other bidders might have other ways to tackle this problem around, creating healthcare consumers who are sophisticated and have transparency into quality of outcomes through providers. There could certainly be other ways to do it. And so that is a potential risk on the PEB side. And so I think it's a fair point that you called it out.
And then again, with the member engagement, and I know we didn't do the financials, I think that before I would want to move forward, I would still want to see the financial parts. Because let's say that we didn't get member engagement for that full year, or not very much of it. How much of that is money that could have gone to something else? But again, I've seen the numbers in the PEB board stuff, so I know that it looks really good. I'm just curious.
Yeah, and we'll certainly talk about that some more in the next PEB meeting. The OEB team will be talking about it this afternoon. We've got a little bit of time before we have that conversation again on the PEB side, but yeah, I mean, that's a reality of, this decision that's in front of the boards. Both boards are in a difficult position from a renewal perspective and meeting the 3.4% cost cap. And so understanding the savings piece is going to be really key.
All right, thank you very much.
Our thought process here is that the evidence and what we had demonstrated for us today has potential for our boards to consider. That's what we're doing today, right? Or sorry, right now. Greg, did you have a comment?
Yeah, I think she stole some of my thunder, but I think, which is perfect. That's the way we should be. I think one of the things, just, looking at the RFP coming up, I'm hoping that this is something we're writing in that will be part of, that we wouldn't have to pay for in the future. It should be part of what a plan does anyway. And so, yeah, just the 1 year is kind of a, do we, give something to them that kind of, that we think works, and then we completely go away from it. So that's something just our board really has to look at.
In the room here? Any more comments or questions?
I think the membership team wrapped it up well. I see real potential for this. I just, again, we just really want all of our members to get the best care possible, least amount out of pocket. We want to control costs. I mean, we have so much to do as boards. If somebody truly wants to partner with us to reach those goals and are not just finding a way to fleece us on the backside, then that I am like, whatever we can do for our members, I think is important.
I'd like to give a shout out that it'd be really cool for us on the OF side if OF and PEB are doing this together, because it gives a lot of leverage. That's a personal thing, but it also looks good if we all agree that this is the best solution we have on the table today. Could be different 5 years from now, but today this is what we both think is right. That's my opinion. Robert,
Well, are we making a recommendation?
About to.
Okay, so I have a process concern. This goes just to OF, is that we're being asked, I guess there are two process issues. One is we're being asked to recommend something to the board that's happening on the same day. I'm uncomfortable with that because part of the consensus that we build at the board level comes from us meeting with our colleagues and discussing these issues. Almost none of what we're discussing today, the board will have access to when they're asked to make a decision today. And so I would like
overview they will. It's part of the agenda this afternoon.
Okay, well, it's got to be a good overview. I guess my point is the overview would be better and better prepared if it weren't happening on the same day.
Time frame for us is
right.
It's, anyhow, keep going.
We control the timeline, so
not
yes.
really. Contract negotiations.
All right, then never mind. Yeah. So no, I was being facetious there. Yeah. So I think going forward, I think we should not do things the same day. The other piece I have on that is that we've had this discussion. We're going to make a recommendation, not seeing the financial part of it, which is going to happen in the next session. So I'm making a recommendation where I haven't seen all of it. So I'm put in a position to say yes to something that I will say yes to, but I'm uncomfortable with that because it's been bifurcated in a way that I don't have all the information to make a recommendation.
You mean this program?
Yeah.
Yes.
But the caveat is, what is SEOW's mission statement? It's to understand the workings and opinions is that it could work. The board this afternoon decides if financially if it's the valid thing to do. All we're saying is this a valid system that could work and benefit our members? Right, from a healthcare point of view.
I just want to reiterate, I'm not talking necessarily about today. I'm just saying in the future, I would like to see it handled a little differently. And the recommendation, then what you're talking about, the recommendation should just be limited to what you just said.
It is.
Okay.
In my opinion, it is.
Okay.
And I think that's totally fair. I mean, there is a second board meeting in April that's reserved a date. It doesn't mean it has to be a 4-hour board meeting. It could be to discuss this.
I mean, that's a lot of pressure on me, so I'm not going to do that.
No pressure.
Yeah. Dr. Laurie, is there a comment?
I think a lot of potential on this, but communication is going to be key. Otherwise, it's going to be a lot of resistance, but then your numbers are not going to be good. And also, I don't want to normalize some comments that I hear here like rural people, they need to drive a lot, and then now maybe they're gonna need to drive longer time because that's not right. So I just want to make that comment. And then I would love to, Nick and Tim, if you can add a request about ethnicity, that would be great. Because you are a new entrepreneur and all that, right? So you want to grow, you want to improve healthcare. That's what we need. Specific and current data regarding race and ethnicity.
Thank you.
Okay, so to summarize up, we at SEOW right now, and oh, sorry, Ali, did you have something you wanted to chime in?
No, that was it. Yeah.
Okay. We're just looking, again, conceptually, is this a program that can benefit our members from a healthcare, quality of healthcare point of view? Is the evidence in front of us effective enough to say this could benefit the healthcare system that we provide to our members? Right? And if it's too expensive, we'll vote it down this afternoon. But from an evidence point of view, can this benefit the healthcare quality of our members? To me, that's the question we're asking right now. Is there an alteration to that comment that I just made? On the phone, sorry, on the board as well. Andrea and Greg, could you hear me?
Yes. So basically, I understand what you're saying. I think that, and I don't want to rehash it, but the issues with communication are pretty big for me of how we're going to get that out and get people to utilize it. People are so inundated with things right now. I do agree that like this, does show value.
Hey, Rose, can I ask you a favor? Can you stop sharing? And Greg, can you have a comment or about what I described there?
I agree with Andrea. I think communication always in new products is huge to get people to move away from the doctor they've been in with for 10 years. It's the only one that's ever seen my kid. I hear that all the time where we're at. But I see value in, yes, something like this, being able to basically have an app. I have a new back pain. I have an app. I open it up. I go here. It saves me money. That conceptually is an amazing product if it works that well, which it seems like it can. But as we said, as was mentioned a little bit, I'm at my primary care doctor and I mentioned that I have this issue. How do we get that person then to say, no, I have this app I want to use? That's the communication part that we need to look at. That's where we need to, if we want them to save, them to save money, us to save money, and move them in that direction. But no, I see potential for it being, yes. It's just that there's people get set in their ways and it's a doctor. So it's just something we have to look at.
It kind of brings back what I said earlier in the meeting, that we can't have the members thinking this is just a system that picks the lowest cost today. It's actually more to the data and more to the algorithm than that.
Right.
And that needs to be clearly communicated. Right. At the same time, Greg, I acknowledge your point that every time we bring in something, there's a communication issue. And so that's normal for us. When we're communicating to 300,000 members, there's always a communication issue. We do what we think is best we can. Okay, I'm going to roll with OEB first. Individually, just give a thumbs up or say you agree with the comment that I made, that this system has potential for benefiting the healthcare outcomes of our members. I'm going to say yes.
Yes.
Yes, so 3 yeses from OEB. We'll go over to PEB. Let's go with Kimberly in the room.
Yes.
Yes. Andrea?
I'd like to not vote.
Okay, abstain? Greg?
As I said, yes, I think there's potential there, but there needs to be some things worked out. There is potential for it.
It's a 2 out of 3, 1 abstain, 2 yeses and 1 abstain. So somebody recording that, I guess. Okay, so that's a go ahead, and should be noted in the PEB meeting. I'll just point that out as the CO that it was 2-1, 2-0-1, right? That was okay, right? We will be discussing the process at each board meeting and go from there. All right, with that said, Rose, any public comment?
No public comment.
All right, anything else from anybody on the board, go to the order?
Thank you. It is a way that we can try the concierge. I want to try it.
Yes, we actually have demo accounts set up for all the board members, so we can send you that access information.
Awesome.
I downloaded the app while you were talking. And but I refrained from logging in because I figured you were going to give us something so that we will. Perfect.
All right, in that case, I'll close the meeting today for SEOW on this April 1st. And thanks, everybody. For OEB members, see you in an hour. Thank you very much.